Good morning, everybody. Good afternoon, depending on where you're joining from. I guess it's still morning here on the East Coast. It's a late morning here, but welcome. This is my favorite event of the weekend. Welcome to the Cozy Pharma weekend. I was just saying here, I'm in Connecticut, and it is truly a cozy day. We woke up to some snow on the ground, so the perfect day to make a cup of tea and get some CE. Dr. Steen, you said it's a little chilly in Florida too.
By Floridian standards, as someone from the north, it is comical to see the ski jackets out when it's 50 degrees, but cooler
Yeah,
than
cooler.
uh, than what is typical.
I'd be out there in shorts right now. Everyone in the Northeast would be like, "Wow, we would take 50." So we have an inch of snow here in Connecticut, and it's just beautiful. So it's a perfect day to spend online, and it's a great way. I love this weekend because it's a great way for so many of us to get so much of our CE done in a weekend with some wonderful speakers and learn a lot. I was just saying I was very lucky I got to hear you present live in the fall in Connecticut, and this is going to be a wonderful presentation. So we're excited to have you. All right, let's see. Well, I know people are still making their way in, but in the interest of time, I know our West Coast people are probably kind of getting their coffee and their breakfast, and our East Coast are getting ready for lunch. But I want to get started because we have a lot to cover today. So welcome to the Woo You Cozy Pharma Weekend. Just a reminder, we'll be here today and tomorrow. So there's 8 hours of CE. But first up, I have the pleasure to introduce Dr. Jessica Steen with Ophthalmic Therapeutics Update. I'm your host, Dr. Jennifer Stewart. And just some reminders for each hour of CE, attendees must be online for a minimum of 50 minutes. This is a 2-hour course, so you have to be online for a minimum of an hour and 40 minutes. So we will go straight through and then we'll leave about 10 minutes for Q&A, and then we'll take a 10-minute break if we're on time, and then come back for the second session for the day. So for a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARPA with OE tracker numbers. We'll also display a QR code at the end of the event. CE certificates will be emailed within 4 weeks. And because this is a longer one, make sure you ask your questions throughout the presentation using the chat and Q&A functions. It's really hard if you have a question in that first 10 minutes to remember it in another hour and 40. So feel free to put those questions in throughout the presentation. We'll make sure we have plenty of time to answer as many as we can. If you're on a mobile device, you can use the Q&A, or chat is behind those those three dots. So it's my great pleasure to introduce Dr. Jessica Steen. She's an associate professor at Nova Southeastern University College of Optometry, where she serves as director of the glaucoma service and as an attending optometric physician at the college's Eye Care Institute. She teaches the courses in glaucoma and ocular pharmacology at NSU. She also serves as the primary care with emphasis in ocular disease residency coordinator. She graduated from the University of Waterloo School of Optometry. Oops, the chat just popped up, sorry. And vision science, and completed her residency in primary care with emphasis in ocular disease at Nova Southeastern University. Her main clinical interests include glaucoma, retinal disease, neuroophthalmic disease with an emphasis in medical and surgical management. Her research interests are centered on artificial intelligence applications in the management of glaucoma. She's a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, a member of the Optometric Glaucoma Society, and the Association for Research in Vision and Ophthalmology, and is the past president of the Palm Beach County Optometric Association. Welcome, Dr. Steen. I am going to turn it over to you, and I will see you back in about an hour and 40 minutes.
Thank you, Dr. Stewart. Thank you, everyone, for joining this morning, from north to south, from the East Coast to the West Coast. Certainly for those of you in the Los Angeles area, we are all thinking of you, your families, including your four-legged family members, your practices, truly your community. And, really as the optometry family, wherever we are in North America, we are with you. And truly, thank you for joining us this morning. This is the beginning of really a big pharmaceutical weekend when we're really looking at the topics, the discussion points. Clearly, there is the emphasis on always driving practice forward. And it's truly an honor to be starting the discussion today. Tracy, kicking things off a little bit later with you, and then the discussions tomorrow. Where we're going to start is almost at the end. We're thinking about what is new within a therapeutic space, what is currently available to us as optometrists to prescribe, and what is in the late stages of therapeutic development that may have a significant impact on our practice and our prescribing habits in 2025 and potentially beyond. I really do think this is such a key, important discussion, not just to understand what we have available to us now to prescribe, but to think about what's coming in the future. This gives us an idea of where trends are leading towards. And, we can really think about how the practical considerations of therapeutics under development can help to answer some of the challenging questions that we have related to patient care, that we have related to unmet needs in management of ocular disease today. Our patients are more well involved in their medical care truly than ever. And it's something that really we need to be that resource for our patients, not just for, again, what we have as available options now, but truly in thinking ahead, what may be coming our way. Now, as Dr. Stewart mentioned, I'm at Nova Southeastern University in Fort Lauderdale, Florida, and one of our crown pieces of the university as a whole, not just in the optometric environment, is our new Center for Innovation. And really, what this environment is truly built, has been built for, is to engage students, faculty, researchers, and private industry together in truly this open type of think tank model. There is robotics development, pharmaceutical development, truly advanced space development that's happening within the connections that have existed between private and public partnerships on a student, academic, and private level. And it's such an excellent example of how different specialties can really drive curiosity and ultimate development, which is such a core, of course, to therapeutics as well. My financial disclosures are here once again. The most important piece is that all relevant relationships have been carefully mitigated. Now, if we take a step back and really do think about therapeutic development, not from a clinical perspective, but from a bigger manufacturing perspective, we can think and really drive and understand where new therapeutic agents may be chosen to be developed over potential other counterparts. Now, if we look at this, we can talk about drugs that may fill an unmet need. This is truly, when we think about this from a clinical perspective, the disease states where, we talk to our patients, we talk about management, but not true treatment. These can be within very common disease states or within a rare disease state. These are truly these first-in-class types of agents, and most recently, within the geographic atrophy space, this is truly where those two now FDA-approved options were aimed to fill this unmet need. We can talk about the rare disease options and the rare disease states that exist with some of the gene therapy products that have been approved and available, and some that may be coming. Well, real gene therapy from an inherited retinal disease perspective is out of the scope of what we're going to talk about. Absolutely, as we're looking into 2025 and ahead, speaking about gene therapy, having a better grasp on what this technology means and how it's utilized and being investigated within the neovascular age-related macular degeneration space in particular is something truly that we will touch on that truly is interesting. And then we can also talk about the development of new therapeutic options that provide us with additional treatment options. So what I mean by that is we've got a number of prostaglandin analogs that are all highly efficacious and highly safe. But when we think about new options that have been available in the last 12 months, how can this help us as a provider? How can it potentially impact the patient's overall adherence through not just efficacy, but potentially through adverse effect profile? We'll look at one example of an intraocular pressure lowering agent under development that the current standard therapeutic is on label for 3 times daily dosing. versus that in development now that is being investigated with just once daily dosing. So we talk about these new options not being brand new drugs, not being treatments for new or different disease states, but strengthening our armamentarium with providing additional options for patients. And then we can break this down in another way and think about these, again, brand new first in class true molecules that are bred out of chemical engineering, the discovery in a laboratory. When thinking about the disease state, finding that piece within pathophysiology that can drive either the further development of disease or could potentially halt or reverse that disease development, and the development of a therapeutic to answer that question or to particularly target a place in the immune system. We can then also think about the curiosity that drives repurpose of molecules. So, for example, we have an agent that may be approved for a therapeutic treatment outside of the ocular space. And could there be a role for that agent within the ophthalmic space? We've seen, again, a successful example of that within the last 2 years, an agent that we will touch on that many of you will certainly have had clinical experience with. Now, I see the development of novel products and these repurposed molecules both as so important to development. Both really are and are driven by answering or asking, to begin with, difficult clinical questions, driving into the science and really diving in and applying this curiosity into pharmaceutical development. Now, very briefly, the overall framework in the United States has allowed for ideally faster, more efficacious drug development, meaning that agents are available to the American population in the most efficient way possible. And, when we speak about regulation and efficiency, those two things really don't classically go together, but there are three particular areas that have helped to drive drug development in the United States. The orphan drug designation that became in effect in 1983 impacts disease states that affect individuals in the United States that have less than 200,000 people affected per year. Now, what the goal here is to incentivize manufacturing companies to develop therapeutic options, not just for these blockbuster drugs that could be prescribed or utilized in large populations, but those very meaningful drugs that may impact a much smaller population. What we see are overall tax credits, and probably the most important is market exclusivity, additional patent coverage for 7 years after marketing, really protecting the patents involved in a therapeutic for a longer period of time. And we also have fast track designation relevant in the geographic atrophy space. This may be applied to therapeutics in development that fill an unmet clinical need. Again, these first in class options. Now, the therapeutic driver that is often used within the eye care space, really any new ophthalmic therapeutic, you'll see this term, PDUFA, Prescription Drug User Fee Act. We'll see a PDUFA date. This is an assigned date that the FDA applies to an agent that's under development. Once the new drug application or biologics license application has been received, this is essentially the delivery date of an answer by the FDA. Maybe a thumbs up, it may be a thumbs down, but it truly is that need by due date that the FDA does designate for a decision based on a product under development. Now, there is the additional question that comes up. There is a significant cost that is related to utilizing this particular program. Now, this is in addition to, of course, all other individual manufacturing and development costs. So the question comes up is that if a significant portion of the FDA's budget is funded through these user fees paid by manufacturing companies, is there any potential influence of the manufacturing company over the drug development process or evaluation process by the FDA? And there has been investigation to determine safety of agents that utilize this program versus those that have determined or had been determined not to. There's no difference in safety that was determined, no difference in class 1 recalls. Truly what we see, in my personal opinion, is working of private and public industry together to ultimately make decisions of therapeutics still based on data. The employees and the staff that work in the drug development pathway and drug approval or evaluation pathway within the FDA, these are clinical scientists. These are laboratory scientists. These are statisticians. It is truly their role to evaluate the safety and efficacy of a product, never to guarantee the safety of a product, but to ensure that any data that's presented is truly credible, number one, and specifies appropriate benefit with acceptable risk. Now, that certainly means that there is some leeway that's there. If we're talking about treatment of a vision or life-threatening disease and a therapeutic aim to treat that disease state, the acceptable risk profile may be certainly higher than for a disease state, for example, like presbyopia. We would be, as a clinician, less willing to accept a specific risk profile for a treatment aimed to treat presbyopia versus a treatment aimed at the management or treatment of cervical, ovarian cancer, or retinoblastoma. So staying up to date, I think, is one of our most challenging, truly challenging pieces. And, I often talk about these two major resources, EyeWire News and Medscape. These are both opt-in systems that you can input your email address to, and you'll get a once weekly update from each of these platforms. Now, I've seen the Medscape ophthalmology platform really change in the last 3 months. And truly, I find it less useful in being kept up to date with what is new, what is important in the therapeutic space or management of ophthalmic disease in general space. This is just pulling from the note. Generally, it's every Friday. They send an email with the real top stories of the week. If we look at the top stories from this past week, I get the personal feel that this is a little bit more clickbait type of material than real scientific data that is truly applicable to us on a day-to-day clinical level. Yes, there is addressing some real important pictures, thinking about diabetic medications, a lot of discussion, certainly again lately, about the impact of alcohol. But really, we're moving away from these breaking therapeutic options or breaking pieces of news that is EyeWire News Core. So to truly be frank, this is something that I'm using Medscape Ophthalmology less for my ophthalmic news and EyeWire News more. And this is just an example of what the top headlines have been over the past 2 days. This is the type of data that is published every single day as an update in the pharmaceutical and ophthalmic space. For those of you that are also interested in the biopharmaceutical space, truly from a business perspective, there is very valuable information that you may find here. And also, of course, of important note, a specific optometry page within EyeWire News. There is more of a specific focus as well. So it's early. Now let's get into this conversation, just, moving one step at a time. I love to manage and speak about management of glaucoma, but we're going to start with a fairly straightforward case. She's 56. She was referred initially for evaluation of suspicion of glaucoma based on her optic disc appearance. I love referrals like this. It's very clear what the optometrist was concerned about in the evaluation of this patient. She's systemically well, no family history of disease, and certainly no evidence of previous elevation in intraocular pressure. Optic discs right on the left side, left nerve on the right side of the screen, and right away, look at what we see when we look carefully. This focal retinal nerve fiber layer wedge defect. And if we follow back to the neuroretinal rim, there is a focal notch in the neuroretinal rim inferior temporal in the right eye. Superior temporal, there is a retinal nerve fiber layer defect. Does that come all the way to the optic nerve? Maybe not at this point. These are large optic discs. They should have a large optic cup, but there is clear notching of the neuroretinal rim in the right. When we look at the left optic nerve, once again, a large but round optic cup with overall healthy neuroretinal rim. Red-free sometimes can help us to evaluate these retinal nerve fiber layer defects a little bit more clearly. And keep in mind the work of Dr. Don Hood. Really what he described in such a beautifully simplistic way is this overlap, especially inferior temporal. When there is damage to the neuroretinal rim, inferior temporally in specific, there is overlap of these axons that supply the area to the paracentral area. We call this the macular vulnerability zone. So when there is inferior temporal optic disc damage, this is truly where there may be a greater likelihood of paracentral visual field damage. We're always thinking about the structure and function relationship, and as we're examining this patient clinically, we're already thinking about what may this patient's function look like, and how can that help us to choose a visual field strategy. This happens to be a 24-2C C to faster in the right and left eye, and just as we thought that we might, there is a very nice paracentral superior visual field defect in the right eye with realistically an early nasal step, clean field on the left. Our OCT imaging, well, at first, when you don't succeed, try again. And, there's nothing that's truly new when we look at the retinal nerve fiber layer. Important objective documentation. This patient has large optic discs. We saw the retinal nerve fiber layer defect inferior temporal in the right eye. There it is, highlighted by OCT again. And when we look at the ganglion cell complex of the right and left, we do have ganglion cell complex abnormality in the right eye in this primarily inferior temporal area that correlates with the retinal nerve fiber layer loss. But maybe this is early ganglion cell complex loss in the absence or prior to retinal nerve fiber layer loss in this patient's case. Now, gonioscopy, this patient has primary open angle glaucoma in the right eye, say open angle with borderline findings in the left eye. Corneal thickness is thin, not devastatingly thin, not average, but on the thin side. Intraocular pressure was never high. So we've diagnosed glaucoma. Now what? Truly, most of our patients, even in 2025, truly do still choose medical therapy first. SLT, as we know, is an appropriate, reasonable option for patients to pursue and something that I offer every patient who is newly diagnosed with primary open angle glaucoma. In the practice environment that I'm in a university center where I am not the provider of SLT. I cannot perform SLT in the state of Florida yet. This is something where most of our patients will choose to stay with me on medical therapy to begin with understanding that if they're not tolerating medication well, then I will refer the patient for SLT to an outside provider and have that patient returned back to our practice. Surgical options, not in this patient's case, in the absence of cataract at this point, realistically, we are still at the point with topical medical therapy or SLT being the most reasonable first line options. So what do we have? Prostaglandin analogs as our first line option. Truly, they do provide the best adherence at FDA approved dosing as they are once daily. Again, before bed, there's nothing magical about dosing a prostaglandin analog before bedtime. It's really, from a practical perspective, based on the potential in increased redness that now we've allowed our patient to have, 8, 6, 5, however many hours that patient sleeps of downtime initially after installation, which is when the redness may be most bothersome. They do have good efficacy overnight and full that at least 24-hour impact. Now, if we talk about escalating therapy, generally, when we're thinking about true maximal medical therapy, we do have, of course, prostaglandin analogs. We have topical carbonic anhydrase inhibitors, alpha-2 adrenergic agonists, beta blockers, rho kinase inhibitors. We do still have 1, 2, and 4% pilocarpine, and did have an individual, what day was that? On Wednesday of this week, who presented, one of my few remaining patients who is truly still taking 4% pilocarpine. This is someone that we are truly, he is not a candidate for surgical treatment, and this is truly someone that we are trying everything to keep his remaining vision, which is very limited. He does use a white cane successfully and is a well-established patient with low vision services. We're trying to keep his functional vision throughout to be maintained through the rest of his life. We are really throwing the kitchen sink at this patient. He's been on this therapeutic treatment for more than 10 years with overall very good tolerability. This is a very rare, truly rare case. Now, from a prostaglandin analog perspective, we do have newer agents available, and it's important to think about these newer agents to, maybe revisit if it's something that we haven't thought about for a number of years, maybe since approval, as insurance and coverage options certainly always are improving and changing as an agent is on the market for a longer period of time, and just to reflect in how some of these new options may be different from my most commonly used prostaglandin analog, generic latanoprost 0.005%. We have latanoprostene bunod 0.024% that is latanoprost acid with this additional side chain that is called butanediol mononitrate. Now, in the eye, butanediol mononitrate releases nitric oxide. Nitric oxide in the anterior chamber acts to increase the spaces between trabecular beams, as well as evidence that it increases outflow pathways downstream. So we've got an additional twist on our traditional mechanism of increase in uveoscleral outflow with the addition of this nitric oxide releasing agent. We now also have true preservative-free latanoprost 0.005%, something our European colleagues and Canadian colleagues have utilized for many years that our patients now have access to. Now, we also have latanoprost ophthalmic emulsion, 0.005%. This is preserved, but not preserved with benzalkonium chloride. It's preserved with potassium sorbate that is a more gentle preservative and uses this classic direct pay model. Now, I think something important just to touch on when we're talking about benzalkonium chloride options versus non-preserved options or more gently preserved options is that traditionally, we've all heard in our career that benzalkonium chloride, first of all, does have a negative effect on the ocular surface. But could that negative effect, as it breaks down tight junctions between epithelial cells, can that benzalkonium chloride increase the penetration of a therapeutic? And theoretically, yes, it can. However, when we talk about efficacy of these molecules, our prostaglandin analogs are highly efficacious molecules. There is, when we look at the data related to the approval in Europe and the United States of latanoprost preservative-free and latanoprost ophthalmic emulsion, these are just as clinically efficacious as are benzalkonium chloride preserved agents. Latanoprost does not need the benzalkonium chloride to be efficacious. That's really the way that I think about it. Could it enhance the overall tissue penetration into the anterior chamber? It can, but does that provide a clinically meaningful effect based on our knowledge of preservative-free and preservative-gentle options? That answer is no. The benzalkonium chloride does not provide a clinically meaningful impact on the way that these medications work. So we can be confident in their number one, efficacy, and number two, safety. Now, for those of you who prescribe latanoprost ophthalmic emulsion, you will know since 2023, we are coming up on 2 years, there has not been the availability of this agent. However, I have heard that this molecule, this particular therapeutic, is coming back. We don't have a date as to when that may be, but it has been unavailable for nearing 2 years, but it is going to be available back on the market. We just don't have a timeline on exactly when that may be. Now, what about Rho kinase inhibitors in the management of glaucoma? Well, Rho kinase, as a family of proteins, are involved in cell shape, cell motility, proliferation, and programmed cell death throughout the body. When we look at the trabecular meshwork, Rho kinase acts to regulate smooth muscle contraction. Now, it has also been investigated in ganglion cell survival, has been utilized in cardiovascular procedures in the reduction and development of fibrosis, and also, of course, in corneal procedures. Now, when we look at the FDA-approved Rho kinase inhibitor and norepinephrine transport inhibitor, this is notarcetal, 0.02%. Its primary mechanism of action is to increase trabecular outflow, again, by altering the cell motility and cell shape by increasing the space between trabecular beams, and also, once again, having an impact on the distal outflow pathway in reducing that background pressure, the episcleral venous pressure. Now, of course, all aqueous to leave not just the eye, but to get out of the periocular area needs to overcome this episcleral venous pressure, which is why in an eye that hasn't had surgery and is not on a Rho kinase inhibitor, the lowest intraocular pressure that we can typically get is somewhere in that 6 to 9 millimeter mercury range, really at the level of episcleral venous pressure. It needs to be, the intraocular pressure needs to be slightly higher than that individual's episcleral venous pressure for outflow to occur. As we're dropping the episcleral venous pressure, this is really a one-to-one reduction in intraocular pressure. Clinically, I have found this medication very meaningful in patients who particularly have low intraocular pressure. Now, I do not see notarcetal as a first-line agent from an efficacy perspective. Prostaglandin analogs are still our most efficacious once-daily treatments, but notarcetal does make an additional add-on or an excellent add-on to a prostaglandin analog, even to the point that it is available as a fixed dose combination, notarcetal with latanoprost in the same bottle, dosed once a day in the evening. Now, the most common and expected adverse event that we do have to make our patients always aware of is redness, is conjunctival hyperemia. Now, this doesn't impact everyone. I describe this to everyone about the potential for increased redness. And this might be bothersome enough for a patient that they are not able to tolerate the redness. And that's in less than 10% of individuals truly find the redness intolerable. So if I think about, 100% of patients in a particular category that are prescribed and started on notarcetal, when they come back and we talk about how they're managing on their therapeutic or new change in treatment, I'll say, about half of patients say, yeah, doc, my eyes are red. I see it, but how's the medication working? I can tolerate this if this medication is working well. A smaller subset comes back and says, Doc, what are you talking about? My eyes look great. They are not red whatsoever. And then that, 8 to maybe 10% of patients will potentially even call a week into therapy and say, Doc, I can't handle it. This redness is too much for me to handle. The challenge is that as a prescriber, we don't know who's who. We don't know who is going to have no meaningful conjunctival hyperemia versus the individual that says, I can't handle the hyperemia. So it is something to make your patients aware of. It does not make me, it is not the reason that I would avoid prescribing this medication in anyone. It's not a barrier to prescription. It's just the knowledge that our patients need to have in knowing what to expect. Patients will develop corneal verticillata. This was demonstrated in lower percentages in the fairly short clinical trial period. In my clinical experience, if a patient is on notarcetal for a period of really about that 8-month period or longer, this is something that you will start to see corneal verticillata develop. This is one of the most significant cases that I have had. This is an individual. This is not a reason to stop therapy. I truly see this development and appearance of verticillata as almost a reassurance to myself that this patient is utilizing their medication every day consistently as prescribed. This is reversible. If a patient were to take a medication holiday, this would reverse. So when I have a patient that comes back and they have this asymptomatic verticillata, I document it, but I understand, again, this is not a reason to stop the medication, but this is something that tells me that this patient is being consistent with their medication use. Now, this verticillata is located, this pigmentation is located within corneal epithelial lysosomes. So we're talking about on a microcellular level. This does not cause corneal staining with fluorescein as it doesn't damage the epithelial cells, but it is medication that binds to cellular lipids and accumulates in epithelial cell lysosomes. Now, where does Notarcetal fit in? Truly, again, not as a first line therapy based on its efficacy profile. And in clinical trials, it does seem to work better with this moderate intraocular pressure, again, making it an excellent option as a second line agent if cost and availability do allow. Now, one piece of unique data that has been published is a particular phase 4 trial investigating the switch of patients from their existing therapy in a real world setting into this fixed dose combination of notarcetal and latanoprost. So, a multi-center American-based open label study. There was no control arm, which is something to be aware of, and these were patients who on their current treatment had intraocular pressure that was 20 millimeters of mercury or more. Really in that ballpark that managing that patient, you might say, I would like lower intraocular pressure. Is there a way that we can achieve this without making their treatment more complex or potentially making their treatment less complex? Patients were either taking latanoprost alone, latanoprost plus one additional agent, or latanoprost plus two additional topical therapeutics. And they were switched to one drop once a day of the fixed dose combination of notarcetal and latanoprost. For those patients taking latanoprost alone, when switched, there was nearly a 5 millimeter mercury reduction in intraocular pressure. Maybe this isn't surprising as this does represent an escalation in therapy. For patients who were taking latanoprost plus one agent, there was still a reduction in intraocular pressure when the switch to this fixed dose combination occurred. And for patients that were taking two bottles of medication in addition to latanoprost, so really 3 bottles total, there was still, following the switch to notarcetal and latanoprost, there was still a reduction in intraocular pressure. I think this is an important reminder for us that topical medication adherence is one of the biggest challenges that we and our patients face. And I really do think that, if we're thinking about switching from 3 bottles to one, how will adherence be impacted? Truly only in a positive way. And I think that's what's really being reflected by this further IOP reduction in that bottom group, latanoprost plus 2 agents. How did a de-escalation or seemingly de-escalation in therapy produce a lower intraocular pressure? I think this is the adherence that's truly speaking. Now, of course, the challenge that we all face is the growing number of prior authorizations that we are required to complete for our patients. And I received another one next week. This is not just for branded agents. This is now my second prior authorization, which isn't many, of course, in the big scheme. However, we are now getting prior authorizations for generic latanoprost. This is just generic latanoprost, 0.005%. This is a very straightforward prior authorization. The one that I received this past week was more complex, that clinical data was required for this patient to be maintained on her generic prostaglandin analog that she's been utilizing successfully for the past approximate 5 years. Now, of course, with branded medications, prior authorizations are a known, often expected step for us and our staff to jump through. Now, this particular example I think is interesting. The hoops that we deal with. This was a particular patient that I believe was prescribed, again, a branded prostaglandin analog. And as we see, a prior authorization was noted to be required. But the pharmacy benefit managing company sent me a very convenient list of the agents where PAs were not required. Now, the top of the list, this is a patient who had failed on generic latanoprost alone, switching to brimonidine or brimonidine timolol, not clinically reasonable. But I looked down and I saw rocklatan at the bottom of that list with no PA, and that was a carrot for me, and I'll say I took it. Prescribed this patient the fixed dose combination of latanoprost and notarcetal, seeing that wow, this patient can maybe get this medication with no PA. I'm in. This is, for this particular case, determined to be an excellent medication choice. Later that day, okay, so maybe a prior authorization isn't required, but the medication is just altogether not covered by the patient's insurance. So truly, the hoops that we jump through are often challenging, but truly, the coverage and the changes in coverage, the development and enhancement in coverage for patients does continue to grow the longer that a drug is on the market. So maybe if you haven't had success with a particular agent that you haven't tried in 2 or 3 years, it is worth giving it another try or speaking to your representative that truly is the expert in coverage in your local area. Now, from a glaucoma standpoint, I do want to touch on one agent called omedanipeg isopropyl. It is FDA approved, but it is not available in the United States. So how does that happen? This is not our typical prostaglandin analog. It works on a slightly different receptor, which means that its mechanism and efficacy and safety profile is slightly different from what we expect with our traditional prostaglandin analogs. Now, efficacy, it does have an impact, seemingly does have an impact on trabecular outflow in addition to uveoscleral outflow. And it does not bind to the receptors that inhibit our soft tissue and fat tissue formation. So while we know that our traditional prostaglandin analogs do cause periorbital darkening, do cause eyelash growth, and do cause loss of periorbital fat with long-term treatment, interestingly, because of the receptors this molecule binds to, it does not cause eyelash growth and it does not cause this change in soft tissue. Now, this might be a cosmetically pleasing for some agent, although it doesn't cause the eyelash change. It does have our typical expected potential pro-inflammatory adverse effects, and it was approved more than 2 years ago. So why isn't it available? Well, the news a year later was planned for launch now a year ago. Now, the manufacturing company had also discussed a new agent under development that is this particular concentration of brimonidine that is being investigated with once daily dosing. Now, the way that they have reformulated this brimonidine compound is not by tweaking the brimonidine itself, not the active ingredient, but the inactive ingredients. We see this in many of our topical therapeutics that how are the many branded versus generic options of loteprednol different or the same? They are all loteprednol in slightly different concentrations, 1%, 0.38%, or generic 0.5%. But what makes that 1% branded loteprednol, the 0.38% branded loteprednol different are the inactive ingredients. This is what we see in the technology with this brimonidine formulation under development that utilizes these microparticles that spread out on the ocular surface with each blink. Now, again, the data related to the submission and evaluation by the FDA was set to come out about a year and a half ago. There has been no news, with the most recent update being planning to launch in early 2025. So to be clear, there's some gray area here. If this agent may be being launched sometime soon, if it's even been approved, but something to look out for and something to be aware of is that not all, just because the active ingredient is the same, not all agents are the same just because they have that same active ingredient. The technology in these agents is really based on the inactive ingredients. This manufacturing company is also developing a difluprednate molecule. So what may have caused the halt of, that omedanipeg isopropyl, the change in the development status related to the once daily brimonidine? Here's the news from the summer. It's not related to the drugs themselves. It's related to the environment that those drugs are developed in. An important piece to keep in mind that is certainly outside the realm of us as prescribers, but highly relevant to the availability of agents that we wish or hope or want to be able to prescribe. All right. There are two sustained release agents that are FDA approved for the lowering of intraocular pressure in individuals with primary open-angle glaucoma or open-angle glaucoma and ocular hypertension. The first is the bimatoprost implant. This is a sustained release implant that is the equivalent of about 2 to 3 drops of bimatoprost that slowly releases over 3 to 4 months, inserted intracamerally. Now, a recent publication identified really real world data related to this agent. Almost 200 eyes, many of them had prior SLT, which again is a real world, complication in assessing efficacy when the patient has an existing treatment on board. What was determined is that while drug release is completed in that 3 to 4 month period, most patients had approximately a 1 year or 12-month effect from 2 to 3 drops of brimonidine. That is quite impressive. Now, this agent is only approved for a single insertion, and that's its clinical challenge or barrier. So this provides 1 year of treatment in a patient's chronic disease. It's a medication holiday potentially, but this is a patient that would likely be back on a topical prostaglandin analog or, of course, necessity of other therapy following. The barrier to the FDA in their why they had not approved this agent, even with additional data for multiple insertions, was the cause or the concern related to corneal edema. Now, in this particular real world evaluation, there was no corneal edema that was observed. The newest, is the travoprost titanium implant. This is a non-refillable titanium implant that is inserted in an operating room. So while the bimatoprost sustained release implant is inserted usually just at the slit lamp with topical anesthesia, this is an agent that the patient needs to be evaluated and treated in the operating room using a surgical gonioprism. Now, but the effect is and has been determined to be for a longer period of time. Overall, about 36 months is really where we're looking for efficacy of this single placement of a travoprost-eluting implant. The travoprost accesses the anterior chamber and eludes through the posterior, or the central part of this particular device. The device would need to be physically and surgically removed with a new device inserted. It is anchored through the trabecular meshwork truly into the sclera. So we've got many options in lowering of intraocular pressure. So what do we really need? Is there anything else that we really need? Really, something that meaningfully lowers intraocular pressure at night is something that would be truly valuable. Prostaglandin analogs do have a nocturnal effect, but maybe something to give a little bit more. There is a device that is available that may help to answer that question. And then, of course, the holy grail in glaucoma management is neuroprotection. Now, nicotinamide and pyruvate together and nicotinamide on its own have been investigated and are currently being investigated as supplements in multiple clinical trials in the United States and abroad. And just yesterday, this was published. So I do want to share this with you as an update of nicotinamide and its use in neuroprotection or potential neuroprotection in glaucoma. So far, there have been 300 patients dosed around the world, and 2 have developed clearly a rare but very important adverse effect that has been determined to be due to high doses of pyruvate. This is acute liver damage or drug-induced liver injury. The first patient was in the United States, 73-year-old woman who had normal liver function at baseline. She was hospitalized, received treatment in the hospital, and at 2 weeks and 6 months, so longer term, liver function is back to baseline. But this was an event that caused hospitalization. The second patient is part of a trial in Singapore who's 69. Her risk factor for determining or for evaluating this adverse event that developed was her low BMI. Could this have been overall, when we think about dosing strategy, an effective higher dosage or overdose for this patient? This particular woman was not hospitalized. She discontinued therapy and within 2 weeks regained her baseline liver function. An important adverse event for us and our patients to be aware of. And in the United States, these episodes or cases of drug-induced liver injury due to nicotinamide really has changed the overall safety evaluation. Liver function testing is being performed at baseline, important, as early as 1 week, at 2 months, and at 4 months, frequently through the trial. This is, again, maybe a very meaningful supplement that can be helpful for our patients with potential significant adverse effect. Now, from a therapeutic development standpoint, there are new technologies that are aiming to help patients sometimes squeeze the bottle on the top right, and also to, I'll say, optimize the amount of medication that's released from a classic or over the classic prescription drug bottle. The nano dropper is an adapter that reduces the amount of medication from that agent that has been supported in the literature in its efficacy. So let's move to the front of the eye. Now, there is an FDA-approved agent that is right now approved for in-office as a diagnostic agent and microdose combination of tropicamide 1% and phenylephrine 2.5%. Now, what's unique about this is that it's not two drugs just in the same bottle, it's two drugs in the same platform that utilizes this device called the OptiJet device. Now, what happens with this device when you press that blue button in the lower portion of the device? It releases a spray, a uniform microdose spray of approximately 8 microliters of medication. Now, this is described as almost like an inkjet printer type of approach. So it's a very fine, uniform amount, but a very dense spray type of profile. Now, interesting, in the clinical trial program, MIST-1 and MIST-2, less than 1% of patients reported stinging after installation of tropicamide 1% and phenylephrine 2.5%. We know tropicamide stings. We know this. Our patients know this. We see it every day. Less than 1% in the trial reported stinging. That, to me, is something that's meaningful to understand that this may have a very strong application, not just in a diagnostic setting, but in a therapeutic setting. And this is, of course, the next steps that are being evaluated. Now, this particular platform and device has been and is undergoing ongoing studies with therapeutic latanoprost and other topical agents. Now, if we think about the adverse effect profile of any topical prostaglandin analog, we're well familiar with them, but could there be a more optimized dosage or dosage that can be released by a platform like this that can improve adherence due to the improved tolerability? Now, something interesting, as a device, there is also the potential to pair with a smartphone app so that we can get, as the provider, a better understanding of that patient's true adherence. So this is where the technology comes into play to enhance agents that currently exist. This is our standard tropicamide and phenylephrine, just using a piece of technology to deliver it potentially more effectively in the sense of a more balanced safety and tolerability profile than what we currently do. Now, in the presbyopia space, we have 2 FDA-approved options, pilocarpine 1.25%, the first. This was an important first step into the field. It's certainly not the last. Maybe it's not the most preferred, but this was a true meaningful step forwards. Now, it is now on label for twice daily dosing, and it was followed by the approval of pilocarpine 0.4%, so a much lower concentration that is preservative-free and on label for up to twice daily dosing. There are a number of agents that are under investigation for the treatment of presbyopia. So what we're talking about is reducing pupil diameter to improve near vision without additional correction, without the reduction in distance acuity. And what we see are almost these blends. We think about it as not just one agent, but maybe highlighting some of the best features from each of these classes of medication to have these kind of proprietary blends to produce this real desired effect. I think about this as winemaking at its finest, right? So 100% Cabernet Sauvignon versus a particular blend to enhance the overall quality, taste, and profile of that product. Now, the agent that is currently under evaluation by the FDA with this decision date of August 8th. So watch for this summer. This will be interesting news to learn whether or not the FDA decides to approve this agent or not. Once again, for presbyopia, this is LNZ 100 or 1.75% aceclidine. Aceclidine, that's a tricky one. It is a small molecule muscarinic acetylcholine receptor agonist, so in the same class or category as an agent like pilocarpine. What I find interesting when I look at the clinical data from the clinical trials of this particular drug is that not just the efficacy, that 71% of patients had a 3 or more line improvement at near, but the time point, 30 minutes. This is fairly quick onset based on what we're used to. And maybe more meaningful, 40% still had clinical effect at 10 hours after installation. Now, the most common adverse effects are listed and again are no surprise for this category of medication, but important as we're thinking about efficacy and overall safety or tolerability profile. In treating a condition like presbyopia, this is something that maybe those patients are less likely to be willing to tolerate discomfort or any other adverse effect considering the disease state that's being treated, presbyopia. So this is where this balance comes into play. 20% of patients reported that the agent caused irritation. 13-ish% of patients reported that dimming that we know can happen when you're reducing pupil size, and 9% of patients reported hyperemia, which was mild. So to be continued, August 8th, by August 8th at the latest, we will have the official answer as to whether or not this is the latest FDA-approved agent in the presbyopic space or not. We do have the FDA-approved option for reversal of mydriasis, phentolamine 0.75%, that acts as a non-selective alpha-1 and alpha-2 blocker. Many of us do remember the previous agent that was approved for this indication, which utilized a different mechanism of action and had an unfortunate overall tolerability and safety profile, which led it to not be utilized. This is what makes phentolamine different, is truly its overall safety profile and tolerability profile. Something interesting I find is that there is clinical trial data that has led to its approval in as young as 3 years of age. We rarely see pediatric approvals in any real topical therapeutic space. So this is unique that there is a large portfolio of data that includes safety and efficacy in young individuals. In the anterior segment space, we have varenicline, the nasal spray that is on label for the signs and symptoms of dry eye disease. This is not just a different route of administration, but a different way of thinking about treatment of dry eye disease. This causes activation of the trigeminal parasympathetic pathway that leads to this lacrimal functional unit activation, causing an increase in production of the 3 components of our basal tear film, causes an impact on the lacrimal gland to produce the aqueous component, impacts the conjunctival goblet cells to release mucin, and impacts the meibomian glands to cause the increase in production of meibum, truly providing a complete tear. Now, it is, again, a nasal spray that is utilized very different than many of the nasal sprays our patients might be used to. And the absolute One adverse effect that all of our patients need to be made aware of that can be improved by placement and truly practice in utilizing this medication is sneezing. That was demonstrated in up to 82% of patients in the clinical trial program. Now, this is an agent that there is additional chair time for you or your technician to really make sure that this patient is comfortable in where to place the bottle of medication itself, and some additional tips and tricks that we figured out along the way and shared with one another that work best in our own offices in reducing the sneezing that occurs with this agent. In 2023, we had, again, a real first in class molecule, 100% perfluorohexyl octane. This is unique as it's not a water-based compound, which means that it can be preservative-free in a multi-dose bottle. Microbes cannot grow in this molecule. This is truly a very interesting engineered molecule that prevents and reduces tear film evaporation. Well supported through clinical trials from a safety and efficacy perspective. Where I find this to be really unique with patients, some of my most absolute sensitive dry eye disease patients where anything, artificial tears, preservative-free tears, burn are bothersome to that particular patient. Interestingly, what I found with using 100% perfluorohexyl is that those are the patients who say this is the most gentle thing I've ever used in my eye. So again, a unique molecule that has really opened up the door to our understanding of these engineered non-water-based formulations. Now, a similar non-water-based formulation is used as the vehicle with 0.1% cyclosporin. So this EyeSol is the proprietary name of this water-free technology that acts to not just increase surface contact time, but also deliver the molecule deep into the tear film towards the surface of the cornea. So again, it's not the same molecule as perfluorohexyl. It's a different molecule designed for a different purpose. While perfluorohexyl is meant to stabilize the tear film. What this particular molecule is aimed to do is to truly deliver the cyclosporin deep into the tear film and to actually evaporate really quite quickly. Now, the other agent that I think many of us have had truly results that we'll see like this, which is something that's quite unique. This is a patient as she is looking down with clear Demodex blepharitis, our classic presentation that's very easy to miss unless you are having that patient look down as part of the clinical exam. This was about after 8 weeks it took her to complete the bottle of treatment. This is no other treatment. This is not lid scrubs. This is not additional lid hygiene. All this person did was use lotilaner on label twice a day in each eye as an eye drop. And, this is something that when we're looking at efficacy, I think what's so unique about a molecule like lotilaner, first of all, this was developed for the veterinary space and then was again reformulated into an ophthalmic agent for the treatment of this parasite. Now, I think what's interesting is the way that the drug, it works on the parasite, not on our body or not on our function. So this is where this reliably, often in my experience, truly comes from. I've found this agent to be reliable in this type of sometimes extreme result because this is the drug working on a parasite. Our body is not impacted. The pharmacokinetics here are a little bit different, which is, again, something unique in the eye care space. Now, under development, we have some news that has come out about this agent Reproxalap, a RASP modulator. This is something that works higher upstream than our typical arachidonic acid pathway that acts to reduce inflammation that is under investigation for dry eye disease and allergic conjunctivitis. It initially did not. It had its need by answer date specified by the FDA, and that answer was a no. So what was required is for additional clinical data to be performed and submitted. That has now completed. The updated application is under review by the FDA, and we'll receive news on this by April 2nd of this year. So maybe again, one more therapeutic entering the space. The third that is under investigation and under review by the FDA is a molecule called acoltramon. This is, again, being investigated in the signs and symptoms of dry eye disease, and it uses a different, again, a creative receptor, what's called the TRPM8 receptor. Now, this receptor is expressed on neurons throughout the trigeminal nerve, and as a topical ophthalmic, where it is being accessed is on the surface of the cornea. Now, activation of trigeminal signaling, just like we saw with varenicline, increases the production of basal tear film. So we've learned and we've better understood the role of trigeminal impact or stimulation through therapeutics. Now, that was with a nasal spray. Now, this is a different receptor that ultimately impacts that same process. So I think this is quite an interesting and truly, again, creative molecule that has been developed, and news that will be released again this spring. There's one more topical steroid that is new. You may have heard of this. You may not have had clinical experience with it yet. I will say I have not yet had clinical experience with topical clobetasol. Clobetasol is new in ophthalmics. It has been well established, if you've heard of it outside of an ophthalmic space. It is a commonly utilized agent in dermatology, really considered a very strong steroid in dermatology. Now, it is FDA approved for the treatment of post-op inflammation and pain after surgery twice daily. Again, in an optometric space, typically we would use this off-label. I am curious in getting some clinical experience with it, specifically potentially in the management of uveitis. Now, again, this uses an additional piece of technology to improve tissue penetration and ultimately efficacy that they're calling nanoparticle technology. So very small molecular structure, molecular size to better penetrate tissue. It is preserved with a low concentration of benzalkonium chloride. And interestingly, only a small number of individuals demonstrated IOP elevation in clinical trials. Now, the trials were approximately overall 2 and 4 weeks long to demonstrate safety and part of the efficacy and part of the safety component. I am curious, as we're talking about such a strong steroid, truly, will our clinical experience give us more insight into the potential increase in IOP elevation in using this medication? Again, we don't know this yet, but I truly do look forward to getting clinical experience with it to better understand its practical safety profile for patients. Now, 2 agents that, again, are these unique agents, these true biologics. One is a topical as Sanedgermin, and the other as teprotumumab as an intravenous infusion. Now, not to go into great detail on these 2 today, but really just to speak to the continued development of new agents that focus on specific pathways as biologically active agents to alter disease states, neurotrophic keratitis and thyroid eye disease. So let's shift gears. Let's talk about retinal pathology, which is excellent timing. Let's start, we used to talk about GA or geographic atrophy as the little footnote at the end of talking about therapeutics. Now this is really at the forefront. When we talk about age-related macular degeneration, we understand that the complement system is a central driver in the development and progression of age-related macular degeneration. There are multiple entry points into this pathway, and this complement system, of course, is an important component of our natural innate immune system. We all have complement. We all need complement. What happens is that in the pathogenesis of AMD, this overactivation or upregulation of the complement system has been implicated as a driver in development and progression of age-related macular degeneration, driving and leading to tissue death. We now have 2 FDA-approved treatments, not to stop, not to reverse geographic atrophy, but to slow geographic atrophy's progression. Something so important for us to understand and something so important for us to communicate to our patients. What does this sound a lot like? It sounds a lot like the management of primary open angle or secondary open angle glaucoma. We're talking about adding a therapy not to stop glaucoma progression, not to get back the damage that's already happened, but to truly slow down the progression in a meaningful way. The first agent that was FDA approved is pegcetacoplan. This is an intravitreal injection. The pooled data overall did demonstrate that primary endpoints were met. They were not quite met in one of the two pivotal trials, which was something interesting to see that the pooled data did meet primary endpoint of slowing the rate of geographic atrophy progression. This is a very large molecule. We are talking about a massively complex molecule. This is technically not a biologic agent. It's a slightly different type of agent. And of course, the interesting and curious safety signal that was determined in clinical trials was this increased risk of exudation. These are patients with geographic atrophy that developed neovascular AMD. And this was significant in the every other month treated group. This was about double from that of the every month treated group. It was about double of that in the every other month or every second month treated group, which again was more than double in the sham group. This is related to treatment. Now, what we had seen is, again, as an important safety consideration, that this is we understand part of the impact of altering the complement system. Now, there is the clinical effect, but the safety profile does need to be considered. And early on, once this agent was utilized in an open environment outside of clinical trials after approval, there were an initial 6 cases that were reported of visually devastating occlusive retinal vasculitis. Now, we learned more about these cases, and this is through the ASRS REST or Safety Committee. What was determined is that most patients had this adverse effect after the first injection, and it was generally about a week after treatment. And the thought was maybe this is the body's reaction to something in this agent that they had been exposed to before. In August, there was a statement that came out from the manufacturing company that said maybe this is just related to the filter and the needle that was utilized. That was determined that there was no association with lot number and filter needle following. And, later on, it was determined we've got so far about 14 eyes of 13 patients who developed this significant retinal vasculitis. This is a rare adverse event, but an adverse event to be aware of. And, what's interesting when you really dig into the data to better understand why this may have happened so that our retinal surgical colleagues and medical retinal colleagues and ourselves can maybe do a better job of choosing patients not to involve or not to consider treatment within. It's interesting that the clinical presentation was this significant pain and rapid anterior segment neovascularization, almost similar to what we had seen a number of years ago with intraoperative use of a specific antibiotic, something kind of similar to that presentation. And the thought is maybe this is related to polyethylene glycol exposure, but there's really more to learn about this. Now, what we know about GA and the clinical trials related to pegcetacoplan, including those that are ongoing, is that GA differs in its growth rate between patients, and the lesions that are outside the center of the fovea do grow more rapidly. This is something for us to be aware of as we are identifying potential patients. Now, the other FDA-approved treatment for geographic atrophy, once again, not to stop the progression, not to reverse damage that has been done, but to slow the progression of GA, is avacincaptad pegol, approved a little bit less than 6 months following the first agent. Now, what's interesting is that in the clinical trials, patients responded differently based on where they were in the world. This was a multi-center international study. And what one of the thoughts was behind that is that maybe patients in the United States or North America responded overall better than those in other areas in Eastern Europe. May have been the level of disease, that maybe patients outside of the United States had more advanced disease. and therefore did not have as clear of a treatment effect. I think an important reminder again for us to say we want to identify patients accurately and early to start thinking about the potential treatment option. This safety signal, once again, of choroidal neovascularization or development of neovascular AMD was also demonstrated with Avastin capped pegol. So once again, it tells us something about this mechanism of impacting the complement system that does increase the likelihood of development of neovascularization. So I think one of the questions that really practically does come up is we have two agents, we have good quality data for both. So which is better? Now, there is no head-to-head clinical trial or comparison. One of the real statistical methods of trying to evaluate two separate or multiple clinical trials together, these are not direct head-to-head comparisons, but comparisons of similar data. So it's called an anchored matching adjusted indirect comparison. Now, this has been published. There is real clinical question of the validity, as this is not a true clinical comparison. This is truly statistical alteration and statistical modeling to try to determine efficacy effect. Both agents are very reasonable. Speak to your retinal specialist to understand maybe which agent or which patient they would like to see referred from you. Now, within the dry GA space, there is another agent that's under investigation. This is called elomeprotide. It's been investigated for years as a subcutaneous injection once a day. Ooh. Now, the way that elomeprotide is proposed to slow the progression of dry age-related macular degeneration is to impact and reduce oxidative stress at the level of mitochondria. Now, in a phase 2 study, it did not meet its primary endpoint. This was really disappointing, truly, and this is coming up on 3 years already. But what they did find is that there was, on OCT, enhanced ellipsoid zone preservation of those individuals treated with the study drug versus those who received sham. This gives structural information that this therapeutic may have an impact on truly keeping the ellipsoid zone and therefore photoreceptors functioning for a longer period of time. Really, what is being described as a proof of concept. Now, something interesting is that even despite this failure to meet primary endpoint in the phase 2 study, they are moving ahead with a phase 3 study, altering what the overall primary endpoint of efficacy is. And this is something that a little bit nuanced, but important to keep in mind the big picture. The FDA does explicitly specify what acceptable clinical trial endpoints are depending on the disease state. This is different in neovascular AMD versus geographic atrophy versus diabetic macular edema. Now, with increased or improved knowledge of the way that a therapeutic may work, there certainly does need to be adaptation of the FDA to accept alternative or maybe more practical or feasible endpoints that may demonstrate a drug's efficacy. So this is where we're seeing this in action with moving forward despite that technical failure. All right. Now, moving towards thinking about what is next and what's actually here that is outside of a therapeutic standpoint is photobiomodulation. We now have an FDA-cleared device that is, again, available for the treatment of individuals with dry AMD. Now, the clinical trial program, the most recent clinical trial program, LightSight 3, its results were released now about a year ago. It included 100 subjects, 148 eyes total, and this was a 2-year study. The patients that were enrolled in this study had high risk intermediate AMD. So we think about this right now. I mean, these patients do not have geographic atrophy, but they're probably going to develop geographic atrophy if we continue with our current supplementation of AREDS2 or AREDS2-like formulation. So what could be beneficial? And it was an active sham because the physician and the patient needed to have some sort of treatment that looked like the photobiomodulation active light. So it wasn't the full treatment, it was a lesser intensity. The thought about photobiomodulation is that it improves active cellular processes. And in this clinical trial, its primary endpoints were met. There was a difference in visual acuity and actually visual acuity gain in patients with high risk intermediate AMD. Most were in that 2040, 2050-ish range at the beginning of the study. So patients over 2 years who were treated with photobiomodulation had improved visual acuity to those who did not. And there was a reduction in individuals who were treated in new onset GA. Wow. Now, November of 2024, this particular proprietary device, the Valeda Light Delivery System, was FDA authorized. So here's how the procedure works. It's less than 5 minutes per session. It is done in a physician's office. Optometry is playing a role in this. And as part of the LightSight 3 protocol, this is what was described. It was 9 sessions over 3 to 5 weeks that a patient received every 4 months over that 2-year period. 3 different wavelengths were used, one in the yellow spectrum, one in the red spectrum, and one near infrared spectrum type of light. The particular choice of these 3 wavelengths are to enhance and alter nitric oxide, vascular endothelial growth factor, and electron transfer. Wow, this is meaningful for our patients, and I really am very curious about how its use will develop within clinical practice, number one. And something important to think about as we're talking about new agents in the age-related macular degeneration space. Let's think about this. All of the clinical trials that are currently underway for geographic atrophy, for neovascular AMD, if you're a patient who has intermediate dry AMD, geographic atrophy, or even neovascular AMD, if I'm thinking about myself as that patient, I would want this therapy. If I'm enrolled in a clinical trial, these are very tightly regulated trials. This treatment will have an impact on how that patient does in their existing clinical trial. But you couldn't say no to an existing therapy, because if I was a patient, I would never enroll in a clinical trial if I knew that there was an additional therapy that's available now that could help. So this is a little outside the box thinking and a little complex and not directly currently clinically relevant, but this is a big deal in any ongoing AMD clinical trial. How are they truly going to manage this approval and utilization in their existing protocols? Ooh, something to think about. Now, to wrap up, two real disease spectra to speak on: the neovascular and exudative disease and treatment of those conditions. And then also we'll touch on gene therapy for just a couple of moments. Now, our intravitreal options that our patients have access to, that we have access to, provided by our retina specialists, truly have outstanding efficacy and have certainly changed the trajectory of lack or reduction in vision loss in individuals with neovascular AMD, with proliferative diabetic retinopathy, and with diabetic macular edema. So now the goal in the development of new agents is primarily to maintain this same efficacy, but for a longer period of time. We think about bevacizumab as a monthly injection. We think about newer options as maybe aflibercept is maybe every 2 months. High dose aflibercept, 12 to 16 weeks. With newer agents, the goal is to increase or have increased durability. The holy grail here, when we really think about it, is about 6 months. So as these new agents are under development and we're learning more about them, whenever you see something that has durability over a 6-month period, that's where we start to currently get excited as representing an additional advancement over currently available treatments. Now, we talk a lot about anti-VEGF agents, and they do form the basis and the bulk of treatment in neovascular and exudative or exudative disease. But there are other pathways that are important. These are not only VEGF-mediated disease. There's tyrosine kinase inhibition that plays a role integrins that can play a role, the Tie2 activation pathway, really these additional pathways that help to support anti-VEGF treatment that again are being developed. If we think about the unmet needs in the management of exudative retinal disease, the one thing I'll bring up is if we think about a patient with diabetic macular edema. Now, the anti-VEGF or again, combination types of agents do play a really important role in stabilizing vasculature and reducing leakage, but they do not directly reduce ischemia. So, our unmet need is something that directly targets the underlying component that leads to diabetic macular edema and diabetic retinopathy, the driver, the support of underlying retinal ischemia. So, we need to really back up as we start to think about advancing treatment. We're really treating the downstream effect that happens because of this ischemia, oxidative stress as a whole. Now, one agent that is, or platform that is now back on the market is the port delivery system with ranibizumab known as Lucentis. This is a surgically placed reservoir that is located under the conjunctiva that again points inwards and sits in the vitreous cavity that holds a special formulation of ranibizumab that slowly releases through 6 months. Now, a patient has to be seen by their retina doc every 6 months for a refill procedure. This is done in office with a special needle that removes any remaining ranibizumab from the device itself and then refills with ranibizumab. It was voluntarily recalled in 2022 initially because there were devices that in that refill procedure, the top of the device, the septum, was being broken and dislodged. Ooh, that is real risk for endophthalmitis. Overall, there were changes to the needle, there were changes to the device, and now it is back and available. It is undergoing evaluation in patients with diabetic macular edema as well. The adverse effect profile in the DME group is much less than that in the AMD group. The most common, or the most, I'll say, visually concerning adverse effect in the neovascular AMD clinical trial data is endophthalmitis. Think about older individuals, sick conjunctiva with this device that's sitting under the conj. It can extrude through the conjunctiva, especially in older individuals. When we look at a DME population, generally younger individuals, there were no retinal detachment or endophthalmitis cases through 64 weeks. Now, we mentioned aflibercept. This is the new generation of aflibercept. It is 4 times the molar concentration of our typical aflibercept with a longer duration of action and increased durability in neovascular AMD and diabetic macular edema. 4 times the molar concentration without an additional adverse effect profile. This again, I think, speaks really highly to the molecule of aflibercept itself, that it is overall an efficacious but very safe molecule. Here's the one barrier from our retinal surgical colleagues in utilizing this Eylea HD or 8 milligram aflibercept is that its package insert explicitly specifies the retreatment criteria after the initial loading dose. Now, remember, every patient is very different. Some patients that have very aggressive neovascular AMD, even on an excellent agent, may need to be injected every 4 to 5 to 6 weeks, which is off-label for high-dose aflibercept. So it's really the labeling that has been a challenge for uptake with many of our retinal surgical colleagues. It is a highly efficacious agent, but insurance coverage, because of sometimes the necessity of off-label dosing, has led our local colleagues to utilize another option. There is brolucizumab. It still exists. It is much less commonly used. It was approved in the fall of 2019, and as you may remember, this was really the first agent that demonstrated this increased duration of effect, 12 weeks, which was an improvement from the previous aflibercept of 8 weeks at the time. The challenge was this inflammation. Again, occlusive retinal vasculitis, which is why I bring this up. This clinically looks very different to the occlusive retinal vasculitis that we have unfortunately seen with pegcetacoplan. The same diagnosis, but very different presentation. These patients were often highly inflamed with not a lot of early neovascularization. So it's even though it's the same diagnosis, it has a very different clinical presentation, which seems to be or seems to mean that it's related to potentially a very different underlying inflammatory or responsive process. Now, faricimab is one of the most commonly utilized anti-VEGF-like agents. It does have one arm of its antibody complex that is an anti-VEGF agent. And the second arm of the monoclonal antibody is an anti-angiopoietin 2 molecule. So we've got two mechanisms of action within the same molecule. Now, angiopoietin 2 is involved in vascular stability, inflammation, and vessel permeability. So it's really this supporting mechanism that clinically what we see is, again, an increased amount of time that is possible between treatments for neovascular AMD and for diabetic macular edema, demonstrated in clinical trials as well as in a clinical setting. Now, most recently, this is, I'll say, is a trend in speaking about our local area. This is one of the agents that when we talk about the newer or these kind of next generation anti-VEGF agents, this is one of the agents that is commonly utilized locally. So if we're talking about faricimab as this new agent that has high efficacy with this longer duration of action compared to other molecules, the question really is for someone who's trying to develop or demonstrate the efficacy of their new anti-VEGF treatment is, well, is faricimab really the new gold standard? And the FDA does produce guidance on clinical trial design and comparators. And in their eyes and in their mind, from a non-inferiority standpoint, if you're developing a new anti-VEGF like agent, you still need to compare it to either ranibizumab or aflibercept. These are the two kind of standard non-inferiority or standard bars to compare any medication to. But faricimab can be used if you're developing a new agent and you show or you believe that your agent can outperform superior to faricimab, you can use that as an agent, but to show non-inferiority has to be compared to ranibizumab, Lucentis, or aflibercept, classic Eylea. Now, here's where this gets truly clinically meaningful for us and our patients is access. And when we look at the approximate current cost of these agents, we are not talking about one-time treatments. We are talking about often years of treatment for chronic, visually devastating retinal disease. And it makes sense why, even despite these wonderful advances, the majority of patients in the United States typically receive bevacizumab as a first-line option. Now, bevacizumab is off-label, as a reminder, for any ophthalmic use. So what happens is that bevacizumab is taken, it's on label for oncology indications, and through a compounding pharmacy, that oncology dosage is then divided and broken down into smaller ophthalmic vials and repackaged for the retinal specialist's office. So patients will pay the $70 for the medication, plus it's generally about $60 to $70 for that repackaging pharmacy charge. They often have difficulty with two charges for one injection, or really three: the injection itself by the physician, the drug, and the repackaging. But when we still, of course, compare cost, this is exponentially less in cost to other molecules. So, what is under development in the United States and is approved in the United Kingdom and the European Union is an on-label formulation of bevacizumab that, again, not approved in the United States, but being investigated. This was evaluated in a superiority trial that was based on the peer dosing strategy. So this now bevacizumab formulation that the manufacturing company is developing to be the first and only on-label bevacizumab compared monthly injections of the study molecule, bevacizumab, in comparison to 5 ranibizumab, Lucentis injections. You think about this in neovascular AMD and you ask the question, who did better? The person who received monthly injections or the person who received 5 injections over a 12-month period? The monthly injection individual absolutely, and demonstrated in the trial, demonstrated clear superiority. Now, the FDA sent this back to the manufacturing company and said, we can't approve it at this time. There are concerns related to manufacturing, but also a lack of substantial evidence which speaks to efficacy. Because the trial design, while determined to be appropriate at one time, the FDA changed their mind. And we think about this clinically, this does not demonstrate clinical efficacy. So they went back to the drawing board. They were required to perform a second trial that, again, randomized their study drug versus ranibizumab with 3 injections. Okay, so injection day 0, week 4, and week 8. This is a very short trial, very different from what we're used to in the development of a brand new agent. And interestingly, here's the blow. The study drug, the study bevacizumab, did not meet the pre-specified endpoint of non-inferiority to ranibizumab when they were dosed head to head in these 3 dosages. Wow. This was, in all honesty, this was a bit of a surprise. Now, this manufacturing company is still submitting this drug to the FDA for consideration. I think about the data that's there, and it did not meet the pre-specified endpoint. They must think there's still a shot, a possibility, potential. There was some efficacy. There was a strong safety profile, but this is interesting. Why I bring this up as far as safety and efficacy is that we are in an age of biosimilars. There are ranibizumab biosimilars. I've got a couple of patients who are on biosimilars right now of ranibizumab. And most recently, there were 5 FDA-approved aflibercept, Eylea, biosimilars in 2024. 0 of those agents are currently marketed because of patent and copyright protection and legal considerations currently, which is quite a story of its own. But there are ranibizumab biosimilars that exist, and it is something to be aware of that your patients may receive. These are similar to, it's a different process, but almost the comparison to branded small molecule bimatoprost versus generic bimatoprost. Now, in this biosimilar biologic realm, the cost of production is very different. These are living molecules derived from active cell lines. So the difference between the innovator, or what we would call kind of the branded innovator drug versus the biosimilar, that cost difference or cost savings is often very small because even these biosimilars are complex and expensive to produce, but they do represent some cost savings to an insurance or to a cash pay environment or economy. Be aware of this. This is something big for 2025. Now, to wrap up, that's a lot of intravitreal injections, a lot of therapy. So what else is there? Important from an optometric space, there are 2 agents that are under development that are oral agents for the management of diabetic retinopathy and diabetic macular edema. The first is APX 3330. It has made its way through phase 2 trials with currently no plan to advance the molecule further, but there is some good quality data that helps to support the patients who received this twice daily oral agent had a reduction in progression to proliferative diabetic retinopathy, really moving the needle from really responsive treatment to more proactive treatment. Another oral monotherapy for diabetic macular edema. I've had a patient who was enrolled in this trial. I don't know if she got the medication or not, and I don't know what dosage. It was either 50, 200, or 400 milligrams for a 12-week period. There had been a topical agent that was being investigated. However, it did not meet its endpoints last year. Now, to wrap up in thinking about what is coming, we're talking about durability of agents. Really, the holy grail are gene therapeutic strategies. And just as a very brief overview, we call when you see AAV based strategies, we're talking about adenoviral associated or adeno associated virus strategies. This is using the capsid and materials from an inactivated adenovirus particle to deliver molecular tissue to a specific location for a specific purpose. In RPE 65 Luxturna, that used this wild type AAV serotype. Currently, we don't see any in the ophthalmic space of expression cassette. This is really more about gene editing or gene silencing, CRISPR-Cas9 type of work. What we are truly seeing are agents that are being developed that are these biofactories. So there's a therapeutic target within a specific overall pathway. For example, angiogenesis is an anti-VEGF type of treatment. And the goal is to insert complementary DNA that is integrated into our retinal pigment epithelial cells and retinal tissue to cause the protein product to be produced naturally by those cells to be a specific anti-VEGF agent. So it's producing or causing our own tissues to produce a therapeutic that currently is injected intravitreally. Now, this is this biofactory that produces aflibercept. Now, it's still in early trials, and so far we have laboratory work that demonstrates protein expression through 4 years. This could potentially be a one-time intravitreal injection done in the office where the patient may be less dependent on intravitreal injections additionally, or may need no other intravitreal injections with their neovascular AMD diagnosis for never mind 6 months, but potentially for 2, maybe even 4 years after a single injection. There is another gene therapy product related to dry AMD and geographic atrophy specifically. This is very early on, but again, targeting the end of the complement system. Again, intravitreal injection to produce a biofactory that secretes an active protein that prevents apoptosis. So once again, early data, very early report, very recent report in turning cells in our body to a true biofactory. There are other routes of delivery that are being explored, not just intravitreal, but suprachoroidal, really targeting very close to the tissue that is most interested or most impacted in neovascular AMD. There is an FDA-approved treatment that utilizes suprachoroidal drug delivery. This is a steroid agent on label for intraocular inflammation. But ongoing is a clinical study that is using a gene therapy product and using an antibody fragment of anti-VEGF as a suprachoroidal agent. So what I have listed is the phase 2 data, the phase 2 study currently enrolling for patients with neovascular AMD and diabetic retinopathy that could receive a different route of administration of an anti-VEGF fragment. The advancement here, or the goal, is a greater duration of action, as this is in an immunologically really more protected environment or more protected hub for the anti-VEGF agent to stay and live within. There also are suprachoroidal drug delivery clinical trials underway utilizing gene therapy products. So bottom line, I know that is heavy to start your day, and you've got Tracy to look forward to this afternoon. But the way that innovations in the therapeutic space have developed and are continuing to develop truly do impact what we do in a clinical environment. It is so important for us to understand what is the latest that's available, what options may our patient benefit from today that they did not and we did not have access to 6 months ago. think about how our therapeutic regimens and treatment strategies are changing. And truly, this is not just about what happens in a clinical environment, but there is a very important role of regulatory powers and control outside of what we can provide in a clinical environment that have such an impact on disease, on treatment of disease, and really do need to continue to adapt to what we see, what we're performing in clinic to ensure that there is safe and efficacious medications that are available to our patients with a variety of ocular disease. Now, with that, any new developments, we're trying to find new treatment targets, reformulate agents, develop or utilize alternative routes, and ultimately, believe it or not, reduce the cost of.
Good morning, Dr. Offerdahl. How are you?
Good morning. How are you, Dr. Stewart?
I'm good. You can hear me okay?
Yeah, I can hear you okay.
I don't want to yell, so I don't have everyone
Well,
else hear
I
me.
I can't hear anybody very well. My husband adjusted something on all three computers that are in front of me. But as long as you guys can hear me very well, then
We
I'm
can
good.
hear you. I know people were saying they couldn't hear before, but she was just going through a dry run of her slides, and we already have some questions. That is awesome. I love seeing that. We've got some
Oh, before we even
questions before
started?
we even started. I think people have already heard you speak in some of your other WooU webinars and already
Good.
know kind of what you're going to talk about. So, got
This
some
one's always a fan favorite.
fans. Well, it is 1 o'clock here on the East Coast. Hopefully everyone had time to grab a quick snack and another cozy beverage. It's a little chilly out still, so a nice hot cup of coffee or a cup of tea as we settle in for the second event of the Woo You Cozy Pharma. Um, and just some reminders, we'll get into the logistics, but this is a 2-hour presentation. So we will finish here just around 3 o'clock Eastern, 12 o'clock Pacific. So make sure you are ready to go. And here we are. So welcome to Autoimmune Disease, Pharmacologic and Functional Interventions with Dr. Tracy Offerdahl. Still your host, Dr. Jennifer Stewart. And just reminders, I know you guys have heard this, but each hour of CE, you must be online for a minimum of 50 minutes. This is a 2-hour presentation. So we will be at about an hour and 40 minutes for the presentation. So we'll leave about 10 minutes for Q&A at the end. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to our with your OE tracker numbers. That QR code will come up at the end during Q&A. So if you have the OE tracker app on your phone, get that ready. CE certificates will be emailed within 4 weeks. And again, make sure you ask questions throughout the presentation using the on-screen floating panels. And if you're on your phone, you know where to find chat and Q&A. So once again, I think this is probably our 10th time together at least. I think I always have the pleasure of introducing Dr. Tracy Offerdahl. She attended Temple University School of Pharmacy in Philadelphia, PA, for both her undergraduate and graduate degrees. Upon completion of her Doctor of Pharmacy degree, she completed a residency at Temple University Hospital. She's currently on faculty at the Pennsylvania College of Optometry at Salus University in the Department of Optometry, where she's the course director and instructor for all systemic pharmacology courses for students in the optometry, audiology, and physician assistant programs. Additionally, she's a practicing clinical pharmacist and she's a fellow in the American Academy of Optometry. Once again, welcome, Dr. Offerdahl. I'm going to turn it over to you.
Thank you, Dr. Stewart. I really appreciate it. And just to dot all our I's and cross all our T's from a financial disclosure perspective, I have a non-salaried affiliation agreement with Pharmanex. I'm a biophotonic scanner operator, but most importantly, any relationships have been mitigated prior to, for the purposes of this CE. So autoimmune disease. I think I've done a shorter version of this previously on a WooU platform, and I'm glad to be back here today. It's one of my favorite topics to discuss, and there are really so many different components to it that it is an interesting discussion, as we look outside of the world of optometry and then, from a more global perspective in terms of people, because so many people have autoimmune disease. It might be something very simple and not all that exciting in terms of morbidity and mortality, or it could be something that is hugely significantly impacting somebody's quality of life and maybe even their length of life. So we're going to get into a lot of different subject matter here and a lot of different medications, but first and foremost, right on this title slide, I just would like to orient you to this kind of Venn diagram. We've got the autoimmune disease in the middle, and I love this. It's so simple. But we've got genetics here. That certainly plays a role. Smaller role than you would think in most situations, but genetics certainly plays a role. Sometimes infections, whatever your perspective on COVID is or was, whatever, there are people who have, are experiencing and who have experienced long COVID. So, from an autoimmune component, and it can be just, horrible for them. Gut microbiome. That is absolutely key to a lot of this as well. We've got to have a good microbiome for many different reasons, and we'll talk a little bit about that. Toxic chemicals. You think of those poor people out in California right now with the wildfires, and not only are they exposed from an emotional and financial perspective, but certainly even from a chemical perspective in terms of the air pollution with the smoke itself, and then also, the chemicals that the planes and helicopters are dropping on the fires. So that's going to be something that they're going to deal with, physically as well in the short term and maybe in the long term with a lot of these folks out there. And then dietary components. So you've probably heard in the news, seed oils are bad, and maybe we'll talk a little bit about that. But the whole point about it is our diets absolutely play a role. And really, a lot of holistic and functional practitioners, if they're interviewing a patient, to come on board into their practice, one of the things they talk about is, in utero, what did your mother eat and drink while she was pregnant with you? And I think, oh, how the heck do I know? I guess I could ask her, but also then, were you a breastfed baby? Were you a formula fed baby, just to sort of get a longitudinal perspective on that. And listen, even if somebody was not breastfed and they were a formula fed infant, that certainly doesn't put a big black mark on your ability to be a healthy adult. It's just part of the equation. So we'll get more into that as well. I love this phrase, choose your parents wisely. Of course, that is not something that we can actually do, but it's just kind of a tongue-in-cheek way to approach some of this. So when we look at just kind of the statistics on our lifetime health, so again, longitudinally from conception to death, and that's really what it is, conception, when that one cell goes to two, two goes to four, four goes to eight, eight goes to 16, et cetera. We are already being impacted by our environment around us, which of course includes what our mother is doing at the time as well. But believe it or not, across, kind of the gamut of just generalizing statistics or epidemiology, 8% genetics, we could say 10%, we could say maybe 12% of our genetics are actually going to play a role in our overall health. So out of a 100% of what impacts our health, believe it or not, only 8 to 12% generally will actually impact our health. And I think sometimes it's an alarming number, because you think, oh man, if that's the case, then I've really, done myself some harm, thinking about lifestyle choices, et cetera. But I'm kind of a eternal optimist. And I always look at kind of glass half full. So I look at that and say, oh my gosh, okay. So if it's 8 to 12% genetic predilection for things, that does not necessarily mean that our genes will express those. And we have some control over that in the large majority of cases. There are certainly some diseases and conditions that are just programmed into our alleles. But from what we're talking about from a general perspective, we have a lot of control over what happens to us from today onward. So, our genetics, obviously, you can't influence by changing. But what we do know, and this is part of the autoimmune discussion or just kind of a longevity, anti-aging, functional medicine, holistic medicine, whatever you want to describe this as, we do know that sometimes changing what we're doing, whether we're talking about nutraceuticals, change in eating, exercise, et cetera, we can actually have an impact on gene expression. And that's what we're looking at here with epigenetics. So maybe, if I said 8 to 12% of our genetics play a role in our overall health, well, then that means 88 to 92% we have control over. So our lifestyle choices, and we'll get more into that, can turn on or turn off gene expression. And I remember actually when the functional medicine doctor that I am currently working with, when he said to me, just because your grandmother, your, two aunts on your mother's side, your father's side, whatever, he said, that doesn't mean that that's going to happen to you. You have the ability to make sure that that gene expression is not turned on. That is such a powerful statement, really. And even if you do already have something, that you have the ability to potentially turn off that gene expression once it has started. So again, just to kind of orient us with some of the terminology that goes along with this, genomics is all of our genes. So, even think of COVID, not to belabor the past, but it was one of the places where we heard, obviously, a lot of talk about like, oh, we've been able to sequence the genome for SARS-CoV-2 and that S protein. And that's why we're able to come up with a vaccine for that particular organism. Genetics are individual genes. And you are already maybe participating in some pharmacogenetics if you're not doing it with your patients. Maybe you are participating or using other pieces of pharmacogenetics. But if you look very specifically, I included for you as optometric physicians, we've got ARMS 2, the age-related maculopathy susceptibility to, and complement factor H. There are so many pharmacogenetic pieces that are important for our patients. But those are two that in most states as optometric physicians, you can check in your patients. Why would that be important? Because most of you probably know, maybe all of you know, that these are two mutations that impact a patient in terms of how they respond to zinc, levels of zinc, and even what their chances are for, progressing to some extent to wet age-related macular disease or inflammation or, choroidal neovascularization. And zinc plays a role in that as well. So it's just an interesting discussion that you already can participate in this and be cutting edge because we don't check pharmacogenetic mutations as standard of care. We can, but it's very expensive. I think the cheapest one you can find is about $500. But I will mention here, because I have the time, the Human Genome Project through NIH is still accepting applicants, and you can get your entire genome sequenced as well as, well, your genome has already been sequenced, but your pharmacogenetics, that's a better way to describe it. So you can get something that's a $10,000 or $20,000 test and get all of the information from that. So anyhow, if you want more information on that, you can just Google it. Doesn't cost anything. And I think they give you $100 at the end of it. Epigenetics is the study of how our cells control gene activity without changing the DNA. That's what we're looking at here. So when we go back to this slide with choose your parents wisely, the 8 to 12% and 88 to 92%, this is what we're talking about, our epigenetics here on the bottom and what control we can have over that. Even if you just start today, it's never too late until we're dead. Then it's too late. So internal and external environments play a huge role. And then this is a really important definition kind of across the board, comparing it to the other definitions. But an exposome, and the pictures are interesting, you can't see them real well, but an exposome is defined as the measure of all exposures of an individual in a lifetime and how those exposures then relate to our health. And this is where you can find exposomal and epigenetic studies and information about them, looking at literally conception to whatever age you are now. And we do know at least, the best data and minds out there, the best evidence and brains out there tell us that probably the most impactful time for an exposome is, in that kind of toddler to young child age bracket. So that's interesting. We can't, regret what did or didn't happen. Hard not to, I suppose, in some cases, but we can make a big impact at any point in our lives. And I also like to say this over here, I put it in the yellow star. If you kind of start with the assumption, and it is an accurate assumption, that we were created to be self-healing organisms, wherever you think you came from, it doesn't matter, whether you think it's an evolution perspective or a creationism perspective, it doesn't really matter. Our bodies were made to be self-healing organisms. And from the minute we are conceived, we have so many insults that are impacting our ability to be self-healing organisms. So how do you eat an elephant? One bite at a time. That's how we have to approach it, individually when we start our journey in this arena. So this is just, again, talking a little bit about endogenous and exogenous free radical formation. Certainly you're familiar with free radicals and oxidative stress because you, as optometric physicians, probably some of you more than others deal in AREDS 2 and some other carotenoid or comprehensive antioxidant support. And that's the theory, right? And the theory plays out. So we know that there are things in our body, just normal homeostasis, breathing in and out produces free radicals. And that's fine as long as we don't have anything else exogenously that is also contributing to free radical formation. So as time, from the beginning of man and the world, as we've moved to now 2024, probably millions of years later, right? Or hundreds of thousands, I don't even know when we predicted humans hit the earth compared to dinosaurs. I'll have to look that up. I'm interested in it now. But when you think about it from that perspective, a lot has changed. A lot of it for the good, right? It's a lot easier to get food and housing and, drill for oil and get someplace faster than riding a horse, et cetera. But those things also further impact our exposome. So normal homeostasis is contributing to this free radical formation and oxidative stress. And unfortunately, that is compounded and then we're taken out of homeostasis when you look at all of these exogenous insults that play a role. And it's, probably not like, oh, I've had a couple of infections, viral or otherwise, and that's a 1, so a mathematical equation. And then my gut microbiome, that's not so good either. So that's a 2. So now 1 + 1 = 2. It doesn't work that way. Then we look at a third thing, toxic chemicals. I was a Navy kid. My dad was a naval officer, pilot. So I lived on Navy bases all over the world. And goodness knows what I was exposed to. We know better now, but 50 years ago, I think we probably did know it wasn't good to dump stuff in the ground, but here we are. So, okay, infections that I may have had, plus a poor gut microbiome at one point, and then toxic chemicals, and then, maybe I didn't always eat perfectly, whatever. It's not 1 + 1 + 1 + 1 = 4. The way this works is it's 1 + 1 = 4, plus another 1 = 8, plus another 1 = 20, plus another 1 = 50. It is a synergistic negative relationship between all of these exogenous insults that we, to some extent, can control. And in other ways, we have no control over. So what do? How do we approach this? We control the controllable in ourselves and in our patients. And it can be a huge impact. So I like this graphic. I always say I'm a visual learner. Oh, I have an errant blue box. We'll just ignore that here on the right. But cellular antioxidant protection. I'm going to read through it real quick because I want you to kind of create a visual of what we're going to go through here. Our body's health depends upon our cells. To slow down aging, limit illness, and prevent disease, we must protect and feed our cells properly. I love that. We must protect and feed our cells properly. How do we protect them? Well, the number one way that we can protect them really, should be dietary, but we can't get everything from our diet anymore like we used to. And most of you maybe know I live on a farm. We have 42 rescue animals. I get more beautiful choline infused eggs on a daily basis. I grow most of my fruits and vegetables, and so I have the best of what I could possibly have. I'm so fortunate. The problem is, no matter what I do to my soil every year to enhance it, the soil is still not the same as it was, 50, 60, 70 years ago. It's a lot harder to get good nutrition out of what we, get in the grocery store, or farmers markets are better, but not always. So we eat right, try to eat organic and look for make sure things we're eating and using for cleaning, et cetera, don't have glyphosate, the Roundup residue that's in and on everything. And then what we can't get from our diet, we should supplement. We should supplement with bioavailable vitamins, minerals, et cetera. And it's the whole antioxidant, oxidative stress, AREDS2 type thinking. It's just a little more broad when we're looking at it outside of macular disease. Cells are made up of atoms. Healthy atoms have paired electrons. We are a giant chemical reaction. That's what we are. We are a biochemical miracle for sure. So and the orange dots are the electrons, or the atoms rather, sorry, paired electrons on the atoms. So yeah, electrons. When healthy cells replicate, they make an exact copy. Free radicals, atoms missing an electron, steal electrons from surrounding atoms, and they alter or destroy cells. So I'm not going to read anything else, but I just want you to imagine our body is constantly replicating cells. And then apoptosis occurs and it's natural dying off of cells, et cetera. But if we don't have a deep enough pool of antioxidant protection, if we don't have a deep enough pool of oxidative stress protection, free radicals all over the place, then we're going to have damaged atoms, damaged mitochondria, damaged cells. And when the only thing we have is a large majority of damaged cells, our body's still going to replicate those cells, except this time they're replicating damaged cells. And over time, it is, it is cumulative, and that's when we end up with things like autoimmune disease. And even cardiac illness, metabolic illness, et cetera. And this is, again, just another graphic kind of looking at this, or a visual. But I just want to introduce another term or phrase, and it says, like cancers, slow burn diseases include the following. And that's what we're looking at here. Autoimmune disease is the definition of slow burn diseases. I heard one speaker talk about it as the fire within, and I thought that is a really good way to describe it too. You may not know you have this slow burn chronic inflammation for 25 years, and then all of a sudden, boom, something happens, and now your body's overexpressing a cytokine, and you end up with rheumatoid arthritis, or lupus, or polymyalgia rheumatica, and then giant cell arteritis, or uveitis, or neurotrophic keratitis, whatever the case may be. That's what happens. So I'm not going to spend a lot of time going through the biologic drugs. It's just kind of a reminder of what we're dealing with. And you folks, as optometric physicians, really have just such a huge number of drugs in interesting categories being approved, probably more so than any other category I can think of, save maybe, some of the fancy cancer drugs that are coming out, et cetera. But the rate at which they are being discovered and approved for, ocular use is remarkable. And of course, biologics represent a lot of those newer drugs. So just to kind of orient you to how different a biologic is to a small molecule chemical, like what we're used to, acetaminophen, amoxicillin, let's see, acetazolamide, Diamox. I mean, even our drugs for glaucoma, right? Most of those are what we call small molecule chemicals. So first, I want to tell you, we've had biologics for a long time. Vaccines are biologics, blood products are biologics, stem cell injections, insulin is a biologic, even our original insulin, that came from animal sources. So all of those are biologics, complex chemicals that take a little bit more care in general than what we are looking at with those small molecule chemicals that I was mentioning. I mean, those, of course, all the literature or the package inserts will say, don't store acetaminophen, Tylenol in your car if it gets really hot or really cold. It may degrade the chemical substance, more quickly. Well, that makes sense. But if you put a biologic in a temperature that is outside the range of normal for that particular biologic, it's going to be destroyed, broken down, or just fall apart structurally so fast. They're just harder chemicals to keep stable. And I'll show you just a couple of graphics to kind of further that discussion. So today, when people are talking about biologics, particularly in optometry, we're talking about second and third generation biologics. Probably the most interesting and far-reaching drugs that we've ever had, for sure. That is an accurate statement. These are genetically engineered products. So they cannot be made using a simple chemical reaction like we can with amoxicillin and codeine and fentanyl and things like that. Mixing ingredients together in a laboratory, the way conventional drugs are made, does not work for biologics. Biologics come from living organisms, plant, animal, human. It's usually animal or human with our biologics. So just look at the picture. This is, slide just says biologic drugs versus small molecule drugs. And you can see here we have kind of the Daltons across the top here with amoxicillin. You can see or aspirin rather, sorry, 180 Daltons. So this is a weight comparison. Insulin, 51 amino acids, so more amino acids, 5,800 Daltons. Growth hormone, which is the somatropin, 191 amino acids, 22,000 Daltons. And then look at this, IgG, greater than 1,000 amino acids. That's a lot of proteins, and about 150,000 Daltons. You can tell just by looking at the size. This is all of these, insulin, growth hormone, somatropin, and IgG are all three biologics. If you look at aspirin, I mean, it's a little light for this graphic, but it is just, a small molecule drug. It's tiny and everything is kind of neatly tight together. It would take a lot more than just, a little bit of cold or a little bit of heat to completely break down a small molecule chemical. But then when you look at insulin and somatropin and then finally IgG, I just want you to see, just look at the structure. I always say that these kind of look like somebody took string or yarn and kind of went, mixed it up together and then set it down and said, here's the new drug. And you look at it just by these graphics alone, and you think, wow, that doesn't look like it would stay together very well. And it doesn't. And then look at something like IgG. That's like 5 or 6 different colors of yarn or string that are just kind of thrown together and they land on the lab table and they're like, oh, it looks like fallopian tubes and a uterus maybe, but we're going to call it a new drug. And if you drop that drug, all the string and yarn is going to fall apart. It's going to come apart. And that's why there are so many strict freezing or room temperature rules, so storage issues with these agents. And also, I always say, don't shake these when you're mixing them. And it's just a much harder drug to kind of keep intact. So biosimilars, last couple of comments here. You've probably seen some biosimilars already. A biosimilar is the quote unquote generic of a biologic. We shouldn't call a biosimilar a generic, but people do, kind of colloquially, people will call them, oh, the generic for Humira just came out. Humira is adalimumab. Well, guess what the generic of Humira, the biosimilar of Humira is? It's still adalimumab, but it's adalimumab ALMX. And then the second biosimilar of Humira is adalimumab QLYN. And then the third and the fourth or whatever. They're all adalimumab, but the difference is they're going to have 4 letters at the end as a suffix, the caboose, that's going to be 4 different letters. And that's what identifies the 10 biosimilars that are available for Humira as being unique biosimilars, because they're never going to be as exact as a true generic to a small molecule chemical. I love biosimilars. I think they're fantastic. There's nothing that has been out there that has given us the idea, even a little bit, that they're going to be problematic. But biosimilar just means it's highly similar to the reference product, and that's the biologic. We call it the reference product, the biologic, or the innovator product. So the only thing a biosimilar rather company needs to do is come up with a structure that has no chemically meaningful differences in terms of safety, purity, and potency. That's pretty good. They don't have to do the work. They don't have to do the studies. They only have to do the biochemical portion of this. So here's what ends up happening. The biologic itself, the reference product, the innovator product from the company that did all the work and spent millions and millions of dollars coming up with this particular biologic structure, they might be charging $16,000 a dose. Or like even in the case of, I think it's Oxervate, Center German, BKBJ, that I think initially, or maybe it was teprotumumab Tepezza. They're both expensive, but it was like $48,000 for 8 weeks of therapy with teprotumumab Tepezza when it first started. A lot. And that's a couple of months worth of treatment, right? A biosimilar is going to end up, if the cost was, 48,000 for the biologic reference product, innovator product, the biosimilar might be 5,000, 6,000, 7,000, 8,000. So not only do you hear insurances having a celebration over this with streamers, champagne, and balloons, but certainly patients do as well, because what this will mean for our patients is that more companies will end up paying for the biosimilars. And that's already happening. So it's good news that we have biosimilars already coming out. Monitoring parameters are something else I just want to mention quickly here, because when I think of biologics, sort of traditional biologics for autoimmune disease, it was things like ones we'll look at, but infliximab, Remicade, etanercept, Enbrel, adalimumab, Humira, and then Simponi and Cimzia, et cetera. Let me start by saying this. I'm going to take one step back before we get to what I'm going to say on this slide. All biologics are immunomodulators. I don't know if you learned them like that in back in optometry school, but that's kind of how I approach it, with students. They have slides and slides of ocular immunomodulators and then systemic immunomodulators. All biologics are immunomodulating and some small molecule chemicals, but we're sticking with the biologics here. So what that means is that they're all modulating the immune system. You probably could have noodled that one out yourselves, right? But what does that really mean? It means that these drugs are tinkering with your immune system. And I guarantee your immune system is not happy about that. Our body's never happy a drug is in it or on it. I mean, even just tears represent a body's response to putting a topical ocular drug, in the conjunctival sac or, on the surface of the eye, whatever the case is. Our bodies are never, ever, you can't give me one drug where you'll convince me that the body's like, yay, I'm glad you're here. It could be life-saving. It could be an EpiPen that's hopefully going to save your life, after an anaphylactic reaction. And your body's never going to say, all right, good news, the cavalry is here. It's like, what are you doing? I got this. Remember, I was made to be a self-healing organism. I can do it. See all this inflammation and redness and constriction of the airways? That's my way of fixing the problem, because the body's idea of homeostasis doesn't look 2 minutes ahead and say, doing that is actually going to kill you. So we need medications for sure. But as immunomodulating drugs that are tinkering with the immune system, the body is not happy about that. So we have a few things that can happen. Let me also then further state, and I'll make my quick comments on this slide. A lot of our biologics, most of our biologics that you'll see here, maybe 60 or 70%, I haven't done the numbers, but a good chunk of them are also immunosuppressive. All biologics are immunomodulating, and many, many of them are immunosuppressive as well. That's why we see this monitoring parameter kind of standard set with a lot of these agents. So you can see the first line, I already, told you what that is. These have high immunogenicity potential because they're tinkering with the immune system, and they come from nature. So it's a double whammy. Small molecule drugs have low immunogenicity because many of them are synthetic, not all of them, but many of them. And when you think of allergies, top 4 or 5 allergies, what are they? I can't hear you or see you, but what are the top 4 or 5 allergies that you see on your patient's medical record, or that they'll tell you? Penicillins, codeine, sulfa, sometimes aspirin. What else? Neomycin, that's another biggie. Guess what they all have in common? All of those, they come from nature. They are naturally occurring substances. So that's why they are commonly seen as allergens, whether it's a true serious type 1 hypersensitivity, or if it's something that's like more of an intolerance, separate issue, separate question, but that's why they come from nature. So many of the systemic agents for autoimmune disease can cause significant and morbidity and mortality in and of themselves, which is exactly what we don't want to do. But we have a big disease where our body is attacking itself, autoimmune, and we have to use big drugs to try to augment the problem. Once a biologic is initiated, many of those that are also immunosuppressive, we watch for any signs or symptoms of infection. So, if somebody ended up with COVID back in the day, 5 years ago, they definitely would not get their dose of a biologic because that could kill them. So they could go from something that maybe was like a mild, moderate COVID or influenza or RSV or even just a common cold can kill somebody on a biologic. Of course, that's a wide range of problems, but if somebody's younger and otherwise healthy, meaning outside of their one autoimmune disease, they don't have much else going on, they're more likely to survive something like this, as opposed to somebody who's older with more dysfunction and multimorbidities. So we watch for any constitutional signs or symptoms of infection, and then patients will not get their dose or hold the dose if they're injecting it themselves with a lot of these. We check for latent tuberculosis, so either a tuberculin titer or a PPD. Remember where you got that little intradermal prick and you measured the area of induration afterwards over the course of a few days. If anybody has a positive PPD, greater than like 5 millimeters of induration after that, they will not get their biologic until that latent tuberculosis and sometimes latent hep C or hep B is taken care of. Because it's a pretty darn good chance that if you have a granuloma in your lungs that you didn't even know about, somewhere along the line you were exposed to Mycobacterium tuberculosis, your body walled off that organism and you got a granuloma in the bottom of one of your lungs. We start you on a biologic that is not only an immunomodulator, but also an immunosuppressive. There's a very good chance that it will convert you to active tuberculosis, and then you'll be very sick and you'll be very infectious. So there's a lot to, kind of consider with these. So I always say, make sure, we're always asking our patients about up-to-date drug lists as much as any other thing, a million other things we have to ask about. Autoimmune disease, why do we use biologics? Most of these I tried to make, really relevant to you professionally and maybe personally as well. We have thyroid eye disease, rheumatoid arthritis, psoriatic arthritis, giant cell arteritis, which is linked to polymyalgia rheumatica, wet AMD, macular edema, uveitis keratitis, geographic atrophy, neurotrophic keratitis in some cases. The list is huge. It's just in those patients that fit this list, their expression of autoimmune disease happened to end up, in their thyroid, which then contributed to thyroid eye disease, or they ended up with polymyalgia rheumatica after some sort of insult. So, this was the day then that their body started overexpressing tumor necrosis factor alpha after they had massive muscle breakdown from a statin. That happened to my mother-in-law, and she almost died from it, and she ended up with polymyalgia rheumatica, and then very shortly after that, giant cell arteritis. So, there's a lot. In my case, when I finally ended up with autoimmune disease, I ended up with rheumatoid arthritis and lupus, and that's just kind of where the roulette wheel spun for me. Your patients are ending up with these problems. Cancer, definitely an autoimmune component. I mean, we know that this arguably has an autoimmune component. I think every day more and more patients and practitioners are realizing I can impact this. I can impact my chances of developing cancer. Or if I do have cancer, maybe I didn't do all the right things, which is maybe part of why I did get cancer. Maybe, not always, but maybe now I can reverse it. So there's a lot of empowerment, that we can think about over the course of this discussion. Many of these diseases, and then we're going to go right into the drugs, people are overexpressing certain inflammatory mediators, very specifically cytokines. So under cytokines, we've got a big list of inflammatory mediators that actually we use on a daily basis in our healthy bodies from the moment we were conceived, and then onward and upward once we were fully a human being, right, at birth. well, that's maybe a poor way to say it, but when we needed the inflammatory chemicals for homeostasis, that's a better way to say it. So it could be interleukins, it could be tumor necrosis factor alpha, it could be our B cells, our T cells, and the adaptive immunity. There's just a huge list of them. I can't tell you what you might overexpress if you have autoimmune disease. Science could tell you, and we could probably measure for it, but most of the time insurance doesn't pay for that blood test either. In my case, I overexpress tumor necrosis factor alpha. How do I know that? Because I used Remicade, infliximab, and infliximab Remicade is a tumor necrosis factor alpha inhibitor. One of my best friends, also terrible rheumatoid arthritis, she started on infliximab Remicade. It did not work. And they said, well, then you must overexpress something else. Yet our disease and our presentation was very similar. So someday we'll be able to figure all that out. But that's what we're hitting. Now, all of these cytokines that we use for normal homeostasis are now being exaggerated because of our exposome and maybe some of our genetics. So are the insults that we're exposed to and some genetic component as well. And now they're becoming sort of like cytokines on steroids. And now these overexpression of specific cytokines is what it will begin attacking our bodies in different places. So these highly sophisticated, and I call them sexy pharmaceutical agents, treat medical conditions and diseases for which we've had no treatments at all, or maybe we've had therapeutic interventions that were not enough, or maybe someone did well on treatment with methotrexate, let's say, and then it eventually quit working. So now we have biologics and biosimilars. These are just a few of what I wanted to show you. I mean, it's, clearly I just cannibalized this from someplace online, this baronrocks.com, but it was a tidy table. So I just wanted to show you like an interleukin-1 receptor inhibitor for rheumatoid arthritis, interleukin-2 receptor for kidney transplant immunosuppression. So organ transplant rejection antagonism, interleukin-2 for MS, interleukin-5 for asthma or any eosinophilic type situation, and then all the way at the bottom, IL-17. So these are just interleukins that our bodies use every single day as part of normal cytokine homeostasis. And look at all the diseases and conditions. So we happen to know that at the bottom, interleukin 17, that tends to be overexpressed more in patients with psoriasis, psoriatic arthritis, ankylosing spondylitis. So now we have a drug, secukinumab, monoclonal antibody, that's available for psoriasis, psoriatic arthritis, or ankylosing spondylitis. Because when you look at the epidemiology of that, science tells us that a lot of those patients overexpress IL-17A. So that's what we're looking at here, the targets for people that express certain cytokines. So I'm just going to run through a couple of these real quick before we get into some that are a little bit probably more pertinent to you, maybe personally, but also professionally. Look at dupilumab, Dupixent. This is used, it was initially came out to treat atopic dermatitis. And it's fantastic for atopic dermatitis. And then we realized because off-label research, et cetera. So not anything that's necessarily labeled initially when Dupixent came out. But we also know that people with inflammatory bowel disease overexpress interleukin-4 and interleukin-13, which is the mechanism here for Dupixent and Adbry. So we started using it in ulcerative colitis and Crohn's. I mean, how do you get from atopic dermatitis to ulcerative colitis and Crohn's? Because it's cytokines that are being overexpressed and your body spins the roulette wheel. And in some cases, it's GI inflammation. And in other cases, it's, atopic skin surface inflammation that's, causing a problem. And then at the bottom here, we have abrocitinib, which is Cibinqo, or upadacitinib, which is Rinvoq. You've probably heard of that one. They advertise quite a lot. This one is a JAK inhibitor. So it's a Janus kinase inhibitor. So a lot of these, by the way, most biologics are sub-Q, IM, and or intravenous. Very few biologics are oral because they're just not stable that way. But JAK inhibitors, these Janus kinase inhibitors, that is literally what they're suppressing, Janus kinase. Many of these are available orally. And then here's a couple more, or a little bit more information regarding the JAK inhibitors. So this Olumiant, baricitinib, and again, the upadacitinib, Rinvoq, JAK inhibitors indicated for the treatment of patients with moderate to severe rheumatoid arthritis. So there we have, that was their original use, actually. Usually we would go to one of these agents when a patient failed sort of the traditional therapy for rheumatoid arthritis. The problem with our JAK inhibitors, this is to, I already mentioned the oral thing. The problem that we're seeing with the Janus kinase inhibitors is that there's some cardiac risk, and we're still studying it, and we really haven't come out with a really good party line on that. I had a doc tell me it was, I don't even remember. I think it was, doesn't matter. It was not an optometrist or an ophthalmologist. And I think I had somebody else tell me this too. But anyhow, I had someone who said that they had a child with alopecia. So they were going to start on a JAK inhibitor. And this mom was a little concerned about like the cardiac risks associated with using a JAK inhibitor. And I said, well, we're still using it, and it is indicated in alopecia of the autoimmune type. So let's do it, and, go ahead and do it. And let's just continue to follow the data. We're not entirely sure of it yet. And let's see, this I kind of mentioned, we're using biologics typically, even in UC and Crohn's, when traditional treatments no longer work or are ineffective. But now in 2025, I almost said 2024, we see more and more people going right from diagnosis, and instead of going through all of the more mild to moderate treatments, if somebody's presenting with more severe disease, then insurances are now allowing, in some cases, us to sort of bypass the methotrexate and maybe the hydroxychloroquine and go right to a biologic. Not all the time, and that's still kind of in its infancy because these are so expensive, but we're seeing it. That's how effective they are. So you see in Crohn's, we see some TNF alpha inhibitors. There's our Humira, adalimumab, infliximab, Remicade, et cetera. But look at our other choices. Integrin receptor antagonists, Janus kinase inhibitors, interleukin 12 and 23 inhibitors, Xeljanz, this one, the JAK inhibitor, as well as the IL-12 and 23 inhibitors. You see those advertised quite a bit, the Stelara. I want to say Cyndi Lauper might be taking Stelara for psoriatic arthritis. And here we're talking about UC and Crohn's. There's a lot of crossover. And some people overexpress TNF alpha and they end up with UC or Crohn's. So there's a lot going on here, right? It's a giant roulette wheel in our bodies, what ultimately determines what organ systems, tissues, et cetera, are going to end up with disease. So you might be thinking, why the heck is metabolic disease in an autoimmune discussion? Well, you would have had to have been hibernating for a couple of years if you haven't certainly heard of semaglutide. Some people call it semaglutide. I don't really care one way or the other. I think it's more accurate, the semaglutide, but whatever. And that would be, of course, the Ozempic and the Wegovy. And then how about the tirzepatide, the twin cretin, which is the Mounjaro, and the Zepbound? How do they fit in here? Well, first of all, they are miracle drugs for people who need them, whether it's the type 2 diabetes indication, plus or minus being overweight, or, moderately overweight or extremely overweight, but also on the weight loss side. And then that list of important considerations even grows. It's not just type 2 diabetes and obesity. It's also cardiac conditions in some cases. It is, kidney issues. It is cancer risks. It is like, hey, these can be microdosed for longevity and anti-aging purposes. I love them for that. But what I want you to understand is it might seem like a weird list to tie all those things together, but metabolic disease is highest in the United States. I mean, we are so far down on the list of health, being healthy people compared to many other places in the world. It's quite embarrassing. So I think the latest statistic, it was late 2024, said that 6.7% of people in the United States are metabolically optimum, metabolically healthy. It really was just metabolically healthy, not even just optimized. 6.7% of people, not adults, not a certain age range, just people, 6.7%. That's terrifying. So I think if any of you have the perspective that using one of these drugs, biologics, for metabolic issues, whether, and most people have very strong opinions about this, which is fine. That's the beauty of living in America. We can all have our own opinions. But, when you look at people who are overweight, very overweight, extremely overweight, having the opinion that it's the easy way out and the only, oh, of course you lost weight, you're on Ozempic or Wegovy or Mounjaro or Zepbound. I mean, there's probably a nugget of truth to that. Not that I would ever call somebody lazy. But a couple things to consider. One, if it was easy for everyone to be thin, skinny, whatever you want to call it, nobody would be overweight. If it were easy, nobody would be overweight. Nobody would have type 2 diabetes. Nobody would have, PCOS. Nobody would have, I mean, all of these things are interconnected from a metabolic perspective. The second thing I want you to consider is if somebody who is, overweight, and we're not talking 5 pounds, people, and I know quite a few people who are like, oh, I have a wedding to go to in 2 months. So, my doc let me use Ozempic for, 8 weeks. I don't know. I think that's a waste of money. But that's just my opinion. To me, that is what's feeding into kind of the negative association with some of those drugs. But not only are people losing weight on these drugs, if they don't have type 2 diabetes, they do lose more weight than people who have type 2 diabetes and also are overweight and use these medications. If you missed that, I'll go through it again in a second. Not only are people losing weight, but their body is completely changing from a metabolic perspective. And you know how that ties into our discussion here? Metabolic disease in and of itself isn't an autoimmune disease. There's a genetic component and maybe there's some, maybe there's definitely an exposome epigenetic component, but it's not, it's not really an autoimmune disease per se. But we know people with metabolic disease and then metabolic syndrome, and then, more serious full metabolic diseases like type 2 diabetes and, high blood pressure, systolic specifically, et cetera, are more likely to have autoimmune conditions. So there is linkage here. So the cluster of conditions I'm referring to here is really for metabolic syndrome. And I just want to orient you to these if you don't know them, probably a lot of you do. Elevated blood glucose. So every year when you get your physical exam, they're checking your blood sugar. And of course the range is always like, I don't know, 58 to 99 milligrams per deciliter fasting blood glucose. So if you're at 99, they're like, 2 thumbs up. You don't have hyperglycemia, but you're probably 2 bites of a Snickers bar away from, if you did it tomorrow fasting, you'd be at 100. So, we know that all of these preconditions, this metabolic syndrome, this pre-diabetes, we have to cross over at some point and the number is 100. But that's a wide range, 58 milligrams per deciliter to 99 milligrams per deciliter. So I just wanted to make sure one of the moderators here wasn't trying to text me. So that's problematic because people think I'm safe as long as I'm a 98 or a 99. Nope, nope, nope. You're very close to crossing over. And then let's look at other things. High blood pressure, in other words, very specifically, 120 or higher millimeters of mercury of systolic. Notice just diastolic isn't here as part of the definition. Abdominal obesity, I think it's 40 inches for males, and I think 35 greater than or equal to 35 for females. Abnormal cholesterol ratios or dyslipidemia, same thing. High triglycerides and low good cholesterol. Where's LDL? Not part of the definition. Not part of the definition because we know, LDL, high LDL is a separate discussion depending upon if you're looking at it from a kind of Western medicine perspective or a functional medicine perspective. But LDL that's super, super high is likely problematic. But what contributes to this metabolic issue the most and ultimately autoimmune disease is the triglycerides and low HDL. So if you've ever heard, oh, my HDL, my good cholesterol is, over 65 milligrams per deciliter. And my doc told me that actually kind of takes away some of the other risk I have. That's true. I mean, having a high good cholesterol is great. Number one remedy, number one treatment for low good cholesterol, low HDL, exercise. None of the drugs we have are really effective at increasing HDL. Pro-inflammatory and pro-thrombotic states. So this is our definition of metabolic syndrome. And we know that if somebody has 3 of the 5 of these, they have much higher risk of heart disease, stroke, diabetes, dementia, cancer. There is absolutely a metabolic component to many dementias and cancer. So I also wanted to add a little bit more to the list here: metabolic syndrome, heart disease, stroke, dementia, diabetes, cancer. And, there's certainly a sugar component to this. If you've ever heard of, sort of simple sugars are not good for us really ever. That's true. And if we have diets very high, not just in carbs, but simple carbohydrates, that especially you see it in kids, right? That are like, oh, I don't like to eat that. I don't like to eat this. But of course, most kids would drink soda, and most kids would, eat gummy bears every day and potato chips and hot dogs. And although hot dogs have protein as well, but I'm saying things that aren't fundamentally good for us, at least all the time. Insulin resistance is already occurring in young kids, and the progression to type 2 diabetes is happening much sooner because of a lot of this. PCOS is considered a metabolic disease, and then non-alcoholic fatty liver disease. Now this is called non-alcoholic steatotic hepatic syndrome or something like that. They've changed the name, but means the same thing. So the incretin system, which the biologics that we're going to jump into here in a second, just checking my time, are remarkable. I just want to show you this. It's a very simple graphic, and that's why I chose to use it. I've used it quite a bit now in the past year or two. This is entitled Pathogenesis of Hyperglycemia and Type 2 Diabetes. Pathogenesis of high blood sugar and then ultimately Type 2 diabetes. Whoops. Look what I have here at the beginning. Incretin system. Incretin effect. That's where Ozempic, Wegovy, Mounjaro, and Zepbound work. And that's why they're so effective. And that's why we are making people live better and longer. Forget the fact that they, cosmetically feel better about themselves because they've lost weight. That's a bonus as far as, I in my brain, that I'm like, oh, that's a bonus for you that you were able to lose that weight and you feel better about yourself, be able to exercise more, et cetera. But it is a game changer in terms of morbidity and mortality. So this is literally looking at, pathogenesis of hyperglycemia as well as type 2 diabetes. So what I'm saying here is the incretin system is decreased in people with hyperglycemia and type 2 diabetes. And that decrease in the incretin system, as well as chronic hyperglycemia, it's still normal blood sugar levels, but it's the 99. And at 100, it's too high. So these are ones that are, your pre-diabetic type thing. Like it's not going to take much to send you over to full type 2 diabetes. So hyperglycemia and an increase in lipolysis, and that incretin is decreased. And that gives increased glucagon secretion and beta cell dysfunction and decreased insulin secretion and beta cell dysfunction, et cetera. And over time, maybe 5, 10, 15, 20, 25, 30, 35, 40 years, people end up with neurotransmitter dysfunction as well. Think dementia, think Alzheimer's disease and other types of dementia. In a lot of circles, and it's probably going to end up as our change in name, that Alzheimer's disease is called type 3 diabetes. And that's not just in a bunch of tinfoil hatters somewhere in, some small lab room. That is, well respected way to describe it in many medical circles. So what I'm saying to you is these medications that we're just going to look at briefly, the Ozempic, the Wegovy, the Mounjaro, the Zepbound, and others in the class, Victoza, liraglutide, Victoza, et cetera. But these 2 new chemicals, semaglutide and tirzepatide, seem to be the best, particularly tirzepatide. Those drugs are working at the top of the food chain here with this incretin system. That's what we're getting with that red arrow. We are getting benefits with these drugs because they increase incretin. They are flipping this arrow to point up. We are making the incretin system work better. And when we do that, we fix this entire cascade. We improve it and maybe completely fix this entire cascade. That's true for type 2 diabetes with or without obesity. It's true for type 2 diabetes with overweight or obesity. And it's certainly true for people that haven't crossed into type 2 diabetes, but are, overweight, extremely overweight, that type of thing. We can augment their future for risk of dementia. It's remarkable, remarkable. So these are called incretin mimetics, most likely, or you may only know them as glucagon-like peptide 1 receptor agonists. So incretin is glucagon. That's what we're dealing with here. So on this previous slide, the incretin system is, glucagon is representing incretin, that type of thing. So exenatide, Byetta, that was one of the originals in this group. Then we have liraglutide, Victoza. Liraglutide, Victoza also very early on had the same company making liraglutide for weight loss. It never really caught on because it was so expensive and it wasn't quite as effective as what we have now. Dulaglutide, Trulicity, some people are even using that for weight loss with or without type 2 diabetes because, for a long time we couldn't get the Ozempic, the Wegovy, the Mounjaro, the Zepbound. But then game changer number 1 came out, and I guess it's been a few years now. 2-3 years, semaglutide, Ozempic, subcutaneous injection. The same company made the same medication, dosed it a little bit differently. So instead of max dose of Ozempic at 2 milligrams per week, Wegovy is max of 2.4 milligrams per week. It's still semaglutide, same company made it. It's just called Wegovy. And then we also have Ribelsis, which is an oral tablet for weight loss. It's also semaglutide. All 3 of these, whether it's Ozempic or the generic Wegovy, both sub-Q injection, or the oral Ribelsis, also semaglutide in tablet form, cost about the same amount of money. So 30 tablets of Ribelsis is about $1,200 a month. That's what it costs me to buy also Ozempic and Wegovy as a pharmacist. So the tablets aren't saving anybody any money. Most of these are coming. The yellow arrow, the first yellow arrow is showing you Victoza. This is also what the Ozempic and the Wegovy look like, different color pens. And then look at dulaglutide. Oh, you see it over here, semaglutide, Ozempic. Look at dulaglutide, Trulicity. This is a slightly different type of injection. You take this little gray cap here off at the bottom. Patients put the flat part on their back of their arm or their belly, and then they hit the green button here on top of the Trulicity, and it auto injects. Whereas the semaglutide, Ozempic, Wegovy, patient actually has to physically shove the needle into their subcutaneous fat, which their needles are so small, but some people prefer the auto injectors. The advertising even looks the same, right? It's the same company. Mechanistically, these agents are stimulating this GLP-1 receptor. And actually, I think I said it backwards before. I said glucagon is incretin. I misspoke. I'm sorry. It's the GLP-1 receptor. That's essentially what's, mimicking incretin. But what happens when we use these agents, type 2 diabetes and or being overweight, obese? Acting as an agonist at this GLP-1 receptor, we see an enhancement in glucose-dependent secretion by the pancreatic beta cells in response to high blood glucose level. Game changer number 1. What does this mean? That means when you eat on Ozempic, Wegovy, Mounjaro, Zepbound, your body secretes, releases insulin after food. That's what our bodies do without metabolic dysfunction and diabetes. This is the first drug that actually mimics our endogenous system, isn't trying to control it or replace it. It's mimicking it. I love these drugs, and I never say I love drugs, ever, ever. We also see a suppression in secretion of glucagon after meals. We see a slowing in gastric emptying. For most people, that's a wonderful part of the mechanism. So when you slow gastric emptying, you feel fuller faster, so more satiated. In a few people, that can be a disaster. People who already maybe have other drugs causing a problem, or they maybe already have sort of gastroparesis, it's not emptying, and then we see some side effects. Some appetite suppression and weight loss. I probably could word that better because we see, pretty darn good weight loss in people. And then here's tirzepatide. I already told you a little bit ago, it's called a twin cretin because it not only acts as a glucagon-like peptide 1 receptor agonist like Ozempic and Wegovy, but it also is acting on that endogenous second part of the equation, which is the GIP, or the GLP rather. It is the glucagon-like peptide 1 receptor. Glucose dependent. Sorry, I get so excited, I get ahead of myself. It's the GLP-1 receptor agonist. We already talked about that. And then the GIP as well, the GIP, the GIP. So the GLP and the GIP. When you are having agonist effect at the GLP and the GIP, you have a drug that is so closely resembling an endogenous system with no metabolic dysfunction that it kind of fools our body into thinking that it's working again. It's more of like oh no, drug. With this, it's kind of like, okay, we might be able to work with this. We might be able to work with this, gang. And that's why you are seeing more weight loss. So let's say people are using Ozempic or Wegovy or Mounjaro or Zepbound for weight loss. That's what they're using it for, 20 pounds or 200 pounds, whatever. The tirzepatide data is better and you lose more weight because of this twin cretin effect. It's working in both receptors. If somebody has type 2 diabetes, so let's say you have identical twins, and those identical twins, one has metabolic syndrome, pre-diabetes as part of it, and they're at that 99 milligrams per deciliter, but they don't have type 2 diabetes yet. The other identical twin does have type 2 diabetes, just diagnosed within the past 6 months. So they haven't had it for a long time, but these identical twins are the same weight. They look the same. They both have metabolic disease. It's just that the second identical twin has crossed over into, type 2 diabetes. You give them both tirzepatide, Mounjaro, same dose, same increase in dose, everything is the same. They eat the same food, etc. The identical twin that does not have type 2 diabetes will lose sometimes significantly more weight than the identical twin who has type 2 diabetes and weighed the same as his twin, but has that type 2 diabetes. That's what we see play out in all studies. So we'll see if maybe there's going to be some dosing changes. I don't know. Maybe more of a food approach with some of these patients, but you see that with the Ozempic Wegovy as well. And here's just, a little bit more of the advertising. They, have real patients in their advertising, et cetera. So adverse drug reactions. Some, as optometric physicians, because you've probably heard about them, you've probably read about them, and it makes you a little bit nervous as practitioners, which it should. But gallbladder disease. So even if somebody's had their gallbladder removed, you still have that hepatobiliary system. We don't remove that. So the hepatobiliary system is still intact. You just don't have your gallbladder, which hangs off the side here. You can see in this graphic, the green part. So what that means is gallbladder issues can be a problem in people on any of these drugs. And it is, more likely to occur if people already have gallbladder stones or end up with sort of gallbladder attacks that pass lots of times after eating really high fatty meals, etc. So we just watch for it and we will look for that kind of colicky, severe pain. Contraindicated in patients with a personal or family history of medullary thyroid cancer or multiple endocrine neoplasia syndrome type 2. So the medullary thyroid cancer, if you look at a thyroid gland, in the middle of the thyroid gland, middle is medullary, there are cells called C cells, the letter C as in cat. It's that type of thyroid cancer, which represents probably around 5 to 7% of thyroid cancer cases. So it's the very severe, more deadly type of thyroid cancer, but it's not the most common. We have seen this in animals, in mice. I think mice. I don't even think we've seen it in rats yet, but that's where our data starts with is small animal models. So we just say we're not even going to mess with it. Maybe that'll change down the line, but it's severe enough and deadly enough we don't want to mess with it. Here's some additional adverse reactions, monitor for depression and suicidal ideation. A lot of that is anecdotal at this point, but when you lose weight and you're augmenting your blood sugar, which then augments hormones, other hormones, certainly we can see changes in serotonin, norepinephrine as well. Everything has some relationship. So you might see changes in somebody's depression, anxiety. So it's something we really have to closely look at and, see. It's simple as a question as to a patient, how do you feel? Generalized anxiety or your depression, do you feel any worse, any better? What are we dealing with here? Loss of muscle, everybody. It is not the drugs that are causing loss of muscle directly. Anybody who goes and gets a gastric bypass, or there's the gastric sleeve, anything that is causing rapid weight loss, fast weight loss, even if it's a starvation diet, or Ozempic, Wegovy, whatever, or are taking the medication, the amphetamines that suppress your appetite. Any of these cause the same thing, loss of muscle, because we go into a state of starvation and our body starts to cannibalize itself. So poor Sharon Osborne, she was one targeted as having Ozempic face, and maybe it's a little thin, but she looks pretty good regardless. She probably maybe didn't need the Ozempic or the Wegovy, but she was one that was in the press. So what do we do for those types of things? We have to look at, whole proteins, supplementing with, whey protein or plant-based protein, also using creatine, even if you're not somebody who lifts weights like I do, or, it's mostly carrying 50-pound bales of hay. I'm not on Ozempic, Wegovy, or Mounjaro or anything, but I take creatine every day and I'll be 55 in a couple weeks. I do lift some weights, but it's more just because I'm postmenopausal and I need to keep my skeletal muscle intact just from a health perspective. Same with people on these drugs. Protein supplementation, usually 1 gram per pound of body weight. So I'm supposed to take in 160 pounds of, 160 grams of protein per day, because, I'm 162 pounds at almost 5'10". That's how much protein I'm supposed to eat per day, just as my age. You add these drugs on top of it, and it's a lot. The creatine, as well as even like collagen peptides for muscle building and skin integrity. Okay, here's this diabetic retinopathy and non-arteritic ischemic optic neuropathy. What do we know? Well, it's not surprising. So I will give you the long and short of this quickly. We have known that anything that lowers blood glucose rather rapidly does potentially worsen transiently diabetic retinopathy. And it has to do with the fact that the retina is being starved from the change in blood sugar, the rapid change in blood sugar, et cetera. So we do see in patients with diabetic retinopathy a transient worsening in the first 16 weeks of diabetic retinopathy in a certain percentage of patients. It's not a huge number. I think the last one I read was maybe, I don't know, 4 to 6%. Don't quote me on that, but it's pretty low. So what's the answer to this? Well, we're still waiting for more data, because the semaglutide and the tirzepatide are the best chemicals that we've had for type 2 diabetes as well as obesity. So we have to wait and see. We know that long term, you got to think long game too, that actually losing weight and lowering their blood sugar on these agents is going to benefit the patient metabolically and their diabetic retinopathy. It's going to improve their diabetic retinopathy. We just got to get through this first 16-ish weeks. So the best minds in optometry, ophthalmology, and even endocrine are saying maybe the best thing to do is to just slowly increase the dose of these agents instead of like doubling the dose every week or 2 weeks, as long as the person's tolerating the lower dose. How about we say we're going to keep you on the 0.5 milligrams of Ozempic for 2 to 3 weeks. Then if you're tolerating it okay, because you have diabetic retinopathy, we're doing it slower, then we'll take you to the 1 milligram, et cetera. It actually starts at 0.25. So maybe take 2, 3, 4 months to increase dose to max dose. Many, if not most, will need the max dose, especially for weight loss. And we think that that's going to help for sure. And then, knowing what they look like from a diabetic retinopathy perspective to start with when they're going on these GLP-1 receptor agonists or the twin cretins, and then monitoring them. The non-arteritic ischemic optic neuropathy, that one's a little bit more difficult to come up with a plan, because the data that's out there are two, maybe three two good studies and one that was really kind of poorly done. The data that they came up with matched to what they did, but the whole study wasn't set up well, because they didn't have, match in both groups, placebo versus active drug, for things like hemoglobin A1C and weight, et cetera. So anyhow, but the two studies that are out basically say that the chances are very low or even almost no chance of non-arteritic ischemic optic neuropathy. But if somebody already has had, or has, I should say, non-arteritic ischemic optic neuropathy, that we do know enough to say we have to be careful using these agents. So, or maybe not use them sometimes. So if people already have this, if they already are somebody that has low vision, or monocular vision, we may need to tap the brakes on using these or keep them in the lower dose range to start with. We definitely need more information. That is the long and short of it. And this is just some of the information if you'd like some of those studies. So we're waiting for some, additional data. And then lastly, for these drugs, insulin resistance is that beast that's starting sometimes in toddlers. And it's just mind-boggling to think that a toddler could have insulin resistance, but they can. And so when people start to have high glucose levels after they eat, mainly because, it should be proteins first as our focus in our meals, and then fat, you really need both of those, good fat for sure. And then the carbohydrates, if you, are still hungry or you want to have some carbs with it, mostly complex carbs are best, but protein and fat, then carbs. That is sort of been reversed. In a lot of cases, it's carbohydrate heavy, maybe some fat, unless you're like my parents, that are always in that mindset of low fat, low fat, low fat. And they're metabolically very healthy, but I'm like, you're 80 and you have no muscle at all because you don't eat anything to sustain skeletal muscle. That's problematic, but it's also problematic from being, the child age, because you start to have increase in blood sugar. So the body secretes insulin, and then you keep eating things that are increasing your blood sugar, still in the normal range, but higher than your body wants. So then your body secretes more insulin. And over time, that insulin isn't decreasing blood sugar at all. So all that extra glucose ends up getting shoved into the easiest path of least resistance. And what is that going to be? Instead of using it for fuel and skeletal muscle in the liver and other target tissues in the body, it just shoves it into fat, shoves the glucose into fat, into adipose tissue. And, then you start to see the increase in weight and further metabolic dysfunction. But these are some improvements and things that we are already starting to see with using these GLP-1 receptor agonists, or GLP-1 receptor agonists, and GIP receptor agonists. Improvement in diabetes-related comorbidities, and I should start with decrease in inflammation systemically. That's slow burn inflammation. That's decreasing. And then we see a decrease in obesity-related comorbidities, cardiovascular disease, diabetes. Type 2 diabetes is an atherosclerotic cardiovascular disease risk equivalent. Even if your heart is healthy, if you have type 2 diabetes, that is a cardiovascular risk equivalent. Sleep apnea, arthritis, cancer, decrease in cardiac issues, improvement in cognitive function, improved bone density, treating non-alcoholic fatty liver disease, and treating polycystic ovarian syndrome. Metformin was the leader of the parade that showed us, kind of just tipping, like just cracking the top on this box of miraculous drugs that will be coming down the line. Metformin gave us a little taste of what was to come. And we're sure fortunate to have this group of drugs. Ocular biologics. So we've got some pretty neat medications in ocular biologics for sure. So treatments for choroidal neovascularization, people that are overexpressing vascular endothelial growth factor. I mean, heck, that was our first foray into, wow, somebody's overexpressing something. We can see that they're overexpressing it, and it's linked to this particular disease or condition. I mean, ocular drugs in patients with choroidal neovascularization in particular really were pioneers in the area of overexpression autoimmune disease, and this is what we're going to end up with. So retinopathy of prematurity, diabetic retinopathy, age-related macular degeneration. So, it's been almost 50 years since the VEGF, anti-VEGF drugs. We need VEGF in our bodies, but we know that too much vascular endothelial growth factor is linked to growth of tumors and cancers, and it's also linked to choroidal neovascularization. So we've got all these beautiful biologics. Some we don't use anymore, like bevacizumab, the Beovu, sorry, the brolucizumab. But we're still using these in many of our patients. Here's a ranibizumab biosimilar. So let me go back one slide. Here's ranibizumab Lucentis, very popular drug for choroidal neovascularization, right? So this is the biologic brand name. We're not supposed to call it a brand name, but that's what it is. Let's be realistic. So Lucentis is the brand name of ranibizumab, and it is the original. It is the OG biologic. Now it's been around since 2006, so biosimilars have come out. So this is still ranibizumab. It sort of has its own branded biosimilar name. They call it Beoviz. But look what this is. It's ranibizumab, NUNA. You have other biosimilars for ranibizumab that will be ranibizumab ILJQ. And then there's a third one, it might be ABCD. Another one might be XYQL. The 4 letters at the end of these biologic names, the generic essentially, they're part of a World Health Organization mandatory nomenclature. It's how the World Health Organization decided probably 10 years ago, 12, 8, I don't know, I lose track of time. But the WHO basically said, okay, well, we have ranibizumab as Lucentis, but now these biosimilars are starting to be researched. When they come out, how are we going to know which patient took what in 10 years if it turns out that, 100 people on a biosimilar ended up with permanent vision loss because of the biosimilar? I mean, I'm just throwing that out there, spitballing as an example. So the WHO said, well, I guess the best way to do that is to make sure that every biologic that comes out as of that day and every biosimilar, because we didn't have any then, must follow this nomenclature system where each unique biosimilar and every new biologic has to have that 4-letter suffix at the end connected to it. So the original ranibizumab in 2006, this was before the nomenclature system existed. So no letters at the end of ranibizumab, but all biosimilars will have 4 letters. So here's Oxervate, German BKBJ. That's the innovator product. That this is the reference product. We don't have any biosimilars for Oxervate yet. But like I said, it included the biologic names too if they came out after the nomenclature system. So you probably know this is an ophthalmic solution indicated for treatment of neurotrophic keratitis. There are lots of things that can contribute to or cause neurotrophic keratitis. It is used 6 times per day at 2-hour intervals for 8 weeks. And we don't have to worry about injection or infusion. And because of that, Oxervate is very well tolerated. I just throw in the storage issues, like I mentioned way at the beginning, that it is stored in the freezer initially, and patients take out 1 vial at a time and you use it as such because it's only stable for 12 hours. No contraindications to speak of. A regular systemic biologic that is oral, like the JAK inhibitors, or sub-Q or IM, tons of contraindications. So this is, again, just kind of showing you a little bit more. This is from the company, but showing you a little bit more kind of how it comes as a solution. Teprotumumab, TRBW, Tepezza. This is a insulin-like growth factor 1 receptor antagonist. So listen to that name again. Insulin-like growth factor 1 receptor antagonist. Insulin's in the name. So this, of course, teprotumumab Tepezza is for thyroid eye disease, whether acute or chronic. Now we can pick up those chronic patients with this drug as well, which is amazing because, most people go through the acute phase never really realizing maybe what's going on because their endocrinologists and their general practitioners are like, no. All your thyroid labs look great because nobody checked the thyroid stimulating hormone, receptor autoantibody. So what is it doing? It is, the drug is plugging into this IGF-1 receptor, and it's basically standing there and sitting in the spot. It's like squatter's rights. And so now the autoantibody cannot plug into that receptor and further contribute to the proptosis and if it's acute, in the redness and, those uncomfortable cosmetic issues that patients have, diplopia, et cetera. So the studies were remarkable. The study outcomes actually exceeded the expectations by a significant number. Specifically, when you look at proptosis, the original optics and optics X study looked at, as long as they see an improvement of 2 millimeters or more of the proptosis, they call it a win. Most of the patients in the original studies had 4, 5, 6 millimeters of decrease in proptosis, and then also clinical activity scores, diplopia, and all of that. Remarkable group of drugs. But we do have, because this drug plugs into insulin like growth factor 1 receptors, you can see hyperglycemia down here is the third one in some patients. So if somebody's, metabolically fairly healthy, they haven't, crossed over into type 2 diabetes, most of those patients will be okay. But patients should be euglycemic when starting these drugs, which means normal blood glucose levels. Second, we're going backwards here, pre-existing inflammatory bowel disease, the ulcerative colitis or the Crohn's. If somebody has UC or Crohn's, starting teprotumumab, TRBW, which is an infusion, can exacerbate that disease. Not unusual at all. It's just that this was the one that was seen in the clinical trials, and it probably maybe down the line, people can have a flare with other diseases of autoimmune ilk. And then infusion-related reactions. Anytime you're injecting or infusing a drug, you can end up with reactions. So sometimes we just pre-treat with a steroid, sometimes acetaminophen, Benadryl, whatever. The only one that's not on here, and I should have thought to put it on here, but now we're seeing loss of hearing in patients taking teprotumumab, TRBW, Tepezza. Not everybody, not by any stretch of the imagination, but I wanted to mention it simply because loss of hearing, you think, oh my gosh, how does that relate to thyroid eye disease? Well, autoimmune. And if somebody already has hair cell damage from maybe, working by jet engines as a pilot for 35 years as a naval pilot like my dad, he already had hair cell damage, even with using, probably ineffective hearing protection back in the day. So he already has, polymyalgia rheumatica as well, and he's got this hair cell damage. So in some patients, then this overexpression of inflammation exerts itself already in the hair cells or other structures within the inner ear, middle ear, and or inner ear, and they can end up with hearing loss when they get this drug. So we're looking at that further, but it is now in the labeling. FDA mandated it. We've got adalimumab, Humira for non-infectious, basically, non-infectious intermediate posterior panuveitis. Great drug. It's labeled for that now, so insurances are paying for it. Since it is a systemic medication, we're going to have all of those components to monitor for constitutional signs and symptoms of illness, for watching use of live vaccines, because if somebody has systemic autoimmune disease and we're giving them a drug that's suppressing their immune system, we have to worry about some live vaccines, cold and flu and COVID and RSV, et cetera. This is the black box warning for adalimumab, Humira, as well as all of its biosimilars. So you have the slides you can read through. We also know that patients on these immunomodulating agents have a higher risk of cancer, and very particularly lymphoma. Not unusual. When you are tinkering with the immune system, immunomodulating, when you are tinkering with the immune system, you always have risk of two problems down the line. Hypersensitivity reaction. It took me 10 and a half years on infliximab Remicade, which I did very well on, to finally have almost an anaphylactic reaction to it. And we knew it was coming because I ended up like with a mosquito bite at infusion site. And then it went, to like the golf ball size in 3 months later, and I was pre-treated, whatever. And the last time I got it, it was pretty bad. So they're like, okay, well, you're done with infliximab Remicade. And it was during that time, trying to get my insurance to pay for a different type of medication, that I went on my functional medicine journey, holistic journey, and that's how I ended up with remission from all of this. Tocilizumab, Actemra, giant cell arteritis, game changer for giant cell arteritis. Fewer steroids for a shorter period of time. I mean, can I hear an amen to that? Amazing, amazing labeling change for Actemra, meaning it's now labeled for use in giant cell arteritis. Very similar black box warning to adalimumab Humira, but of course, there's always going to be slight changes in the verbiage. So we're great on time. I may not get through every single slide, in great detail, but what I want you to see here is that our patients are expecting, you as optometric physicians and me as a clinical pharmacist, they want that early detection. They want wellness, most of them, not all of them, and they want prevention more than anything. And now that we've kind of gone through and discussed together or shared together that exposome and how much it can impact our bodies and our patients' bodies, and that 88 to 92% of who we are, we can impact. We can impact for our patients by recommending certain things. You already are doing it. If you, are even looking at dry eye patients, the typical dry eye, where you can use cyclosporin, that's an immunomodulator, with the Cequa. I mean, Cequa is so much better than Restasis in most patients because of that nanomicellar technology and the, lipophilic and hydrophilic components. Even the Centergermin, BKBJ, Centergermin, the oxyrvate, Lifitegrast, that's an immunomodulator. You're already doing that. So AREDS2 and on, teprotumumab, it's wonderful. So you have tools already at your the tips of your fingers in a lot of cases where you can look for early detection and then potential preventive opportunities there. That data doesn't necessarily match the AREDS2 completely, and that's okay. We use the AREDS2 data, you use the AREDS2 data very specifically for macular disease risk, and if they have choroidal neovascularization, for sure, trying to prevent that, et cetera. I mean, I'm butchering all of that, but you get the point. You're already doing some of that with AREDS too. But, for other patients that, maybe have other autoimmune diseases, you can in your offices start addressing that oxidative stress. And there are so many good products out there. I mean, think of the brand names that are available to you guys in all the different companies, and ones outside of optometry that are wonderful as well from a comprehensive antioxidant perspective. And really, that's one of the things that changed my life and put me in remission for my autoimmune diseases. And then biomarkers, it's just a test that has meaning. All these things that you do on this previous slide, Rabin cone contrast test, the ERG, the ARMS2 and complement factor H testing, et cetera. OCT there at the bottom right, all of these are biomarkers. And you hope that a biomarker is going to be one that helps you intervene with the patient today so that you can prevent something happening later. That's some of the best things we can do for our patients. So that's what the predictive biomarker is. Hemoglobin A1C, C-reactive protein, vitamin D levels, omega-3, carotenoid levels. And I mean, there are several carotenoid measuring devices available out there, and they are game changers for patients. I call myself a biohacker. My mother hates it when I say that, but I don't think she quite gets what it means. It's basically, I'm going to change what's happening around me and what I put into my body or on my body. And that means that I'm going to have an impact on my own, morbidity in terms of staying healthy while I'm alive, and maybe mortality. I mean, listen, if I'm not healthy at 78, I don't want to be here. So I want to kind of biohack my way into health and longevity. This is what we can impact, this particular graphic that I was describing. So many people, me included at the time when I ended up with significant autoimmune disease at 32 years old, and I'll be 55 in a couple weeks, I told you, my pool of antioxidant protection was like not even a little bird bath. So when I was exposed to things, when I was going through internal stresses, whether it was emotional, physical, whatever, I didn't have enough. I had like a little measuring cup full of antioxidant protection for my body to pull from. And when that was empty, I had nothing. And so my body went on for many, many years with that subterranean inflammation to just keep replicating damaged cells, damaged mitochondria. And if I hadn't had autoimmune disease already and decided that I was treated with these drugs and I still felt like hell, and my disease had slowed down in progression, but I mean, I've got all kinds of permanent issues in my body from the RA and lupus. I finally decided, well, why don't I at least try it? What do I have to lose except money? And, it was life-changing. So this is part of the equation. So then when I started to do a comprehensive approach to antioxidant protection, I went from a little bird bath or measuring cup full of antioxidants on a daily basis to having like an ocean of antioxidant protection. So no matter what I'm exposed to, no matter what my body goes through, I know that I at least have enough antioxidant protection so that those electrons that are missing on, a cell with oxidative stress can be replaced immediately. So my body's replicating healthy cells. Not completely. We can impact this chronic and low-grade inflammation. Of course, I try to get as much as I can from diet, but all of these things, even what I grow here right outside my window, where I, see all my goats munching, and we have pregnant goats that I'm going to get goat milk from again in April. I'm big on raw milk. That's got to be a decision for you, but that's, something that I do. The nutrients are still not the same, no matter how hard we try. So when it's not enough, and how do we know that? How do we know if our food's good enough? Well, do those tests that I showed you. Get the carotenoids measured for you and for your patients. And it tells you whether or not you have enough protection that you're getting from food. Our cell membranes, all over our bodies, as well as in the eye, are vulnerable to oxidation. We know that. And when we start supplementing, or improving our diets, that's where we get all of the things that work together. I mean, of course, we know that lutein, zeaxanthin, are what's needed in the inner retina. But why are we being so myopic that we're only hitting the inner retina? I mean, the AREDS2 data, of course, led us to that. But don't we want to fix systemically? I mean, this is end organ disease, right? So why don't we want to kind of work on systemically what's going on as well? Because when we work on it systemically and replace our antioxidants, we're automatically going to have an improvement in our inner and outer retina, in ourselves and in our patients. We need all of these things and more because everything works together. So when people are like, "Oh, I'm supplementing CoQ10 and quercetin like it's my full-time job," I'm like, "That's wonderful, but you need the others too. You need the others for cell membrane support, immune support, oxidative stress mitigation, and cell signaling strength and improvement." If you've done any of those things, and probably every single one of you here has done some supplements, fish oil. And oh, by the way, let me go back to the picture. We need omega-3s. Our bodies are, rife with omega-6. Most people, if any, especially in the United States, need omega-6 supplementation. You don't. We have plenty of it just from our diets and seed oils, et cetera. But omega-3s are, generally something that are low in a lot of people. And think of, the evaporative dry eye people. Some of the data is a little iffy depending upon your interpretation of the DREAM study, but you need fish oil, omega-3s, or from flaxseed, vegetable and non-fish-based sources of omega-3s. You need to take a lot more of it than fish, but it works. We need those. They prepare the cell membrane to receive the vitamin C and the beta-carotene and the lutein, the zeaxanthin, the vitamin C, the vitamin A, the vitamin D, the vitamin E, etc. So we need omega-3s as well. Otherwise it doesn't make much of a difference. Probiotics here at the bottom. I've got some, different companies that I use for a variety of things, but I try to stick to 2 or 3 different companies. But probiotics, man, I will tell you what, look up Akkermansia muciniphila. Akkermansia, Akkermansia. Akkermansia. Look it up. If you want specific recommendations on what I use, just, shoot me an email or a text. Completely changed my life. And I lost, I think, an additional 17 or 18 pounds just by recolonizing my gut and throwing some Akkermansia muciniphila in there. It's remarkable information that's out there. I looked for it forever, but it's an anaerobe, and an obligate anaerobe is hard to keep stable. But there's one company out of California that makes a product that is wonderful. I don't work for them. They don't do anything for me, but other than make wonderful products that change my life. So, we're all trained as allopathic practitioners, unless we were fortunate enough to do some schooling in, the Eastern countries, Middle Eastern, or, many countries in Europe. We don't do that here. We are allopathic to a core, but why can't we be allopathic and integrative? Because integrative just means let's look for the root cause and see if we can change that root cause. So if you have chronic reflux, quit taking the well, I shouldn't say quit taking the PPI. Think about trying to stop that proton pump inhibitor over time. Start with some acromantia for you or your patients. You can recommend it for your patients, because when you do that, you are fixing maybe what might be the root cause. When we fix the root cause, we can start to decrease and eliminate the drug. And then we reverse, or at least not worsen, the actual disease itself. So integrative just means, or functional means functional is a better definition for it, but integrative means best of both worlds. Functional means looking for the root cause. We should all be doing that. If your patients are smoking cigarettes, you can say to them, dude, smoking cigarettes is not making your macular inflammation and disease any better. You've got to stop doing that. That's part of the root cause, the cigarette smoking. You're already doing that in your patients. All right, rounding out the last 1 or 2 minutes here, 2.5. We're doing great on time. I know you can't really read this, and I knew that making the slide and presenting it to you. But what I want you to see here is, X and Y axis. You see life expectancy in years, and then you see health expenditure per capita. All of these light gray lines is every other place in the world that lives longer, and their government or persons individually don't have to spend as much money on themselves. They're living to be in their 80s. I mean, we did that for a while. And now if you look at the US, I mean, we're not even talking completely developed countries. We're talking some developing nations are doing better than we are. This is the US. I think this was 2018 or 2019, but it worked. So I was like, I'll just stick with this slide. Yeah, it's 1970 to 2018. This is us. The health expenditure per person over time is, greater than any place in the world. And we live it to be 78, 79. And most people don't feel good at 78, 79. I mean, my parents in general, other than my dad took a fall around Thanksgiving, so he's been, healing from that, but they're on no medications for heart disease, metabolic, whatever. I mean, they're 81 and they walk 6, 7, 8 miles a day because they're, healthy. Most people are not fortunate enough to be like that. They're just very regimented, and they always have been. If I'm not going to live to be 81 and be able to walk and, work on the farm here, whatever, I don't want just improvement in mortality. I don't want you to make me live longer if I'm going to feel like hell for, most of my older life. And that's the problem with a lot of the drugs. We're just like, got a drug for that, got a drug for that, got a drug for that, got a drug for that. And, sometimes patients don't even care about root cause. They're like, nope, I like my cake for breakfast every day. And that's what drugs are for. So we have a lot of different ways that we can impact ourselves and our patients. And there's sure as heck a lot of data on complement factor H and the ARMS2 genetic mutations, and and how they relate to zinc levels in some cases, et cetera. You've got your OCT where you can see oxidative stress with the drusen. You have a lot of tools at the tip of your fingers. And I mean, heck, I'm not an optometrist, I only play one on TV, but you see the drusen down here, and, reversal of drusen, maybe not completely, but pretty close here on the date above it. And I think it was maybe 8 or 9 months apart, if I recall. This is from a friend of mine, one of his patients' OCTs. But anyhow, sometimes you lose the drusen because of disease progression. But in this case, it was, kind of flattening of the drusen because of integrating comprehensive antioxidants in those patients. We've got lots of different components we have to hit, but the good news is we have control over them. So as we round it out here, I'll get to the last slide. All this is just supporting data and interesting information. So You have lots of opportunities as optometric physicians for yourselves and for your patients. And you know what? If you improve your life or one patient's life, that's a win. That's a win. Thanks, everybody. I really appreciate you having me here today. One of my favorite topics. And, you know, reach out if you have any questions or comments.
Thank you, Dr. Appledall. That was awesome. That was so much information. I'm always jotting down notes and looking up supplements as you're talking, and it's always very inspiring and so different than our typical presentations. It's a great
Good.
approach and a great way that you describe these medications that we're all hearing about. I mean, I don't think a day goes by where I don't have a patient on one of the medications you mentioned, but understanding how they work now really helps me
Yeah.
talk to them about it.
Let me see if there were any specific questions. Just the
Do
one,
you,
can you comment on omega-3 versus omega-7 supplementation? So I don't know a whole heck of a lot. I mean, I've heard about omega-7 supplementation. I don't think there's nowhere near as much data with omega-7 compared to omega-3s. So I can't say much other than I sort of stick with evidence-based stuff. But I can certainly look into it and see if I can come up with any additional comments on it. I don't really know much other than I stick with what the data supports, for decades now. Let me see if there's anything else.
there's some in the Q&A. Do you want me to read them for you or you want to go through them?
Let me see, only because my volume is so low here. Let me look in the Q&A. I know, let me get out of here. Maybe you can read it because I should keep
Sure.
this slide up.
Okay. Can you address the relationship between autoimmune disease and personality type?
Oh, that's an interesting question. So I don't know if I would say exactly personality type. I mean, I guess you could say that. And the only reason why I hesitate a little bit is I don't know, maybe it has some negative connotation. I mean, if you look at my personality type or sort of my emotional baseline. I have ADD. I'm a high functioning ADDer for a long time, and thankfully I've controlled it. It was worse through menopause, but I basically control it with diet and supplementing like medium chain triglycerides and ketones, et cetera, and that's remarkably effective for me. But I'm kind of in that personality category where I'm like all the time. I get up at 4:10 in the morning and I'm out the gate, out the door, feeding the animals. I am just go, go, go. And I'm also not somebody who gets really upset, at least what you would see inside. So instead, it's, chewing me up inside. My functional medicine doctor always says, you need to learn to punch walls or scream at somebody because it's not good to keep all of that stress in your body. So, in cases where people are internalizing a lot of stress, physical stress, emotional stress in particular, those patients compared to somebody who does mindful meditation, breathing exercises that get their dopamine surge from, going on a walk or going in a sauna or a cold plunge, whatever, we know that it's a much more likely to have that as, a big component of their exogenous stressors. And also, by the way, the gut microbiome plays a big role in all of that, even with depression, anxiety, et cetera. So maybe not specific personality traits, but more just neurotransmitter based. So go look at that akkermansia.
Thank you. There was just a comment that autoimmune disease is probably one of the three most common problems that a doctor sees with his patients. And just wanted to remind everybody if they see a stubborn or severe case of ocular surface disease, to check for autoimmune disease, run the labs, or refer them out. Would you agree?
Yeah, the itis tells you everything, or at least that they have autoimmune disease component, at least.
Any thoughts on autoimmune protocol diet?
Autoimmune, so like FODMAP, or there's something actually called autoimmune diet. And there are different, ways to approach it for sure. Lots of times we do, in functional medicine, a full elimination diet. Sometimes we start with FODMAP and then go even deeper and more extreme with a true autoimmune diet. I think they're remarkable. I mean, diet plays a huge role in autoimmune disease prevention, autoimmune disease controlling, and autoimmune disease reversal. So yeah, any of those. I've done so many. And as a kind of PS to that, look into intermittent fasting. Doesn't necessarily work for everybody, but intermittent fasting is something that I've used since COVID. And between, my supplementation, working with the new functional medicine doctor, I've always been big into exercise, ridden horses, all the time. But I lost, I think, 65 pounds just by intermittent fasting, working more tightly on the autoimmune diet, and that was remarkable for me. Nothing
Um,
else.
any suggestions on supplements for people with kidney disease?
Yeah, that's the person that asked that. Shoot me an email and we can talk a little bit more about it. I mean, a lot of them are safe for people with kidney disease because, even though they get excreted in the kidneys, they don't really impact kidney function in terms of vasoconstrictive properties or anything like that. But what we want to make sure is that a person that has kidney disease, and of course there are so many different types, but if somebody has kidney disease, which I do, by the way, as part of my lupus, I have one functioning kidney and the other one is not. Um, most of the things that I would recommend would be safe. So we can talk more about that. It would be easier just to do, in a call or text or email.
Um,
Great question.
do you recommend seaweed for omega-3 supplementation as an alternative to fish oil?
Yeah, I mean, I wouldn't say that seaweed, you'd have to eat a lot of seaweed, and I have no problem with seaweed, as kind of food and supplementation. I do like seaweed. The only thing that I would caution against, there are people who, cannot take fish oil because they either don't like it or there's a personal or religious reason why you don't or can't take fish-based products. That's fine. But the one thing that I would caution you about is that if you're going to do the seaweed, if you're going to do, English walnuts, flaxseed meal, all of sort of the vegetable based omega-3 products, your body has to biotransform that twice, which if you're young and healthy, no problem at all. But all of us as we age have a harder time taking seaweed or the flax meal, English walnuts, and all the other things that give us our plant-based or non-meat based, non-animal protein based omega-3s. It's a lot harder for our body to do both conversions. Whereas if you're using an omega-3, you only have to do one step. I mean, I kind of do the final step. I take many times, I waffle back and forth, but I take many times the actual metabolic last step. So my body doesn't have to convert it at all because my body doesn't convert it well from EPA DHA to the completely bioavailable form. So if anybody has questions on that, that's probably the third company that I like to use that has a really good product.
Well, there's a great comment I just want to relay to you. Thank you for going over some more natural options, supplements, vitamins, and nutrition. I love hearing about more holistic treatments and how they compare to conventional options. So, just some
Good.
comments thanking you for your different way to approach this, and both for us as doctors and also people. There's a lot of questions, and I see so many questions asking you specific recommendations for supplements, and I think that's a great place
Yeah, shoot me an
to keep.
email.
Yep, that we just sent her Dr. Offerdahl's email in the chat, so make sure you save that. I know she would be glad to pass along some recommendations. That's probably the number one question that's in the chat. So I know you'll be getting some emails. But I just want to thank you. That was a wonderful presentation. Always great to hear something completely different than what we typically hear in presentations. And as I've moderated your events many times, there's a lot of great comments and questions that come from that. So thank you for sharing your amazing knowledge with us.